will see these long-term survivors with no recurrence at the end. And you can see it here at 36 months, 24 months, and it's becoming clear at the end. So the tail on the curve, again, we are seeing it here. Let's look at the PD-L1. Do you see a difference between CPS negative or positive? No. Yes, it's a smaller number of patients. You cannot really judge, but at least from what I can see here is a clear separation in favoring durvalumab plus FLOT. Pathological response. Here it kind of correlates. If you are seeing patients who went in bad CR because of chemo plus IO, you will see it's kind of a lymphoma curve. Straightforward. However, those when they combine those with partial response, complete response, you will see the curve is totally different. So I have few patients went in bad CR, so I hope they have maintained this curve. Durvalumab does not impact FLOT delivery, and this is very important. If you look at the pre-op, all patients or majority of the patients received it, and there was no difference. No one delayed because of immunotherapy issues. Now, no impact in post-operative, because if you compare placebo plus FLOT versus durvalumab plus FLOT, 73 is similar. So again, 50%, they could not receive all FLOTs. I would offer FLOT with durva for all patients. And if you look at subgroup, all TAB score 1, below 1, more than 5, yes, you probably we will see more responses with higher TAB score, but all patients did benefit. Now again, Keynote 585, the main cohort was cisplatin 5FU, so probably if it's FLOT would be a winner too. And that's why I'm saying if you look at the event-free survival, it's similar to what we are seeing. Matterhorn, although the Keynote there was some overlapping here, but in general, you are seeing similar rates of event-free survival between the Keynote and the Matterhorn. FLOT is a stable modern era. Here we are talking about FLOT 4 in the Matterhorn, similar curve, but if you add durvalumab, you can see how clearly help the patients. Does adjuvant immunotherapy in the perioperative setting? You know, because I always question myself, so if I don't get the adjuvant setting, or would I be okay? Is the neoadjuvant really what helps? So if you look at all cancer types, you know for a fact that neoadjuvant is the way to go. Adjuvant is not helping that much. HCC are, most of the adjuvant setting are negative, and I can mention to you some of the clinical trials here. Here, let's talk about attraction. So attraction is basically they took patients with gastroesophageal cancer, resected, and they gave them chemotherapy plus nivolumab or chemotherapy alone. And relapse-free survival was the primary endpoint, and there was no difference. However, if you look at those with PDL expression, you will see they tend to have some survival. But remember, the number here is only 15 patients. So you cannot really rely on this. So adjuvant setting, because you don't know what to treat. Maybe there is no disease at all, and you're treating nothing. Now, adjuvant nivolumab after chemoradiotherapy. And here we are talking about CheckMate 577. Then we go up here with the chronically relapse-free survival. What was it? 22 months, doubling compared to 11 months, adding nivolumab post-concurrent chemo radiation. But look down there in the CPS 5 and above, it had more benefit. And that's what we are seeing even in the metastatic setting. And this is the disease-free survival. No major toxicity, but really have disease-free survival was helped by adding nivolumab. Overall survival, number-wise, numerically is higher, but they had the problem of getting a lot of alpha in the statistics to the disease-free survival, and that did not show in the overall survival, but there is a separation of the curve. Most of the patients, they will be, or the help gonna be for those with CPS positive. So am I gonna give adjuvant nivolumab for CPS positive only? Honestly, as of now, I will give it to all patients. Biomarkers. Who check biomarkers before giving treatment for gastric and gastroesophageal cancer? 1, 2. كل هياخد فلوت شوف انت تقولي ليش يعني بس خليني اخلص. So I honestly check MSI. Here too is a reflex test in the hospital, so we get it, but it's not going to impact much. So MSI high is the way is very important. I honestly don't offer chemotherapy at all for MSI high gastroesophageal cancer. I do have 6 patients where their gastric and gastroesophageal cancer MSI high and got NEO-AB, 5 of them pathological complete response. So you don't want to play around with MSI high. Now, and why I'm doing NEO-AB? Because of this trial. Low dose AP, 1 milligram per kg plus nivolumab 240, 2 doses of AP plus 6 doses of NEO-P. Then they will go for surgery, then they will continue 9 cycles or 9 months, it's Q4 weeks of nivolumab. And what we found is 60% complete responses here. And محتاجين في GI oncology such curves, you know, لأن كده خطوط مستقيم. طيب, do we have other regimen we can give? Trimidorva, and Trimidorva was given in this clinical trial, but it's a small number of patients. But you can see here that gastric and gastroesophageal cancer, they got similar to the STRIDE regimen. 1 dose of Tremi plus 3 doses of Dorva. And they had a few cohorts. One cohort will go for surgery and one depends. In complete response, they will go for surgery. Those with complete response, they will go for non-operative management. I have a patient who decided she randomized herself after I gave her NEO-AB to not to go for surgery. She cannot because it's not clinical, but she decided I'm not going to go for surgery. So I end up doing scopes and scans, and she's doing just fine and nivolumab. So a lot of patients, or at least half of the patients, they were 75 and above and high-risk population, similar to what we've seen in the NEO-AB. We are talking about pathological complete response of 60%. Now, those who went for the abortion, they did also as good as those for surgery. And you can see it in these curves. Adding anti-HER2, do you think it would help? But,
yes, yeah.
And
Robert tried design.
Robert tried design. بس ما بدي حاطين بول فما سووا Robert tried design. So no, it did not help. And I can tell you from the Petrarca, yes, there was higher pathological complete responses. But there are people dying in this clinical trial. Adding trastuzumab plus pertuzumab plus flood compared to flood. So it was negative. And even if you think about it as, can I go back?
Dr. Ali. Okay. Yeah.
Okay. So
good timing.
Good timing. So HER2, adding anti-HER2 to chemotherapy did not help. At least did not translate in overall survival. It's mainly pathological complete responses. Thank you for listening to me.
Assalamu alaikum. Sabah khair. Moderator, Dr. Ahmed Zahrani for the upper GI session. Now, how many speakers will finish on time? 30%, 50%? We'll see. Okay, so it's my honor to present the next speaker, Dr. Ahmed Shehri, consultant medical oncologist, well experienced in the medical oncology field, associate professor in King's Health University. He will be talking to us about the role of immunotherapy in the metastatic setting. Dr. Ahmed, thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Roa, for the kind introduction. Thank you, Dr. Ashwag, and the rest of the scientific and organizing committee for the kind invitation. I was given the role to talk about immunotherapy in metastatic gastric cancer mainly, so I'll focus on the metastatic part. And as a quick introduction, as Dr. Ali mentioned, gastric cancer is not one of the common cancer diagnosis in Saudi Arabia, but globally, it constitutes a big disease burden. As you can see, it ranks number 5 globally as incidence, Number 5, as a mortality is a highly deadly disease. Despite of all of the nice talk Dr. Ali has given, we still struggle with gastric cancer recurrence and death because of metastatic disease. If you look at Saudi Arabia, specifically, you can see that Saudi Arabia is not one of the highest reporting countries when it comes to gastric cancer. You can see in Saudi Arabia, it ranks number 11 among different cancer types diagnosed in the kingdom. We know we got some sort of struggle when it comes to overall survival. We didn't succeed to improve a lot. Despite of the huge improvements that we had so far, the median survival for most of the patients would be less than 12 months. We still have the first line constitute like the doublet chemotherapy, platinum 5FU, plus minus immunotherapy or monoclonal antibody, according to the biomarker testing that we usually test for. These are the recommended biomarker tests that we usually test for. I usually request the first 4 in the first line, including HER2, PD-L1, MSI, and Claudin 18.2. Now is being added in our pathology kind of request as a reflex test for all newly diagnosed cancer patients. The last 2, the tumor mutational burden and the NTARC, I don't do it on a routine basis, to be honest with you, unless you have a patient who might be candidate for future systemic therapies. I may request like NGS looking for these rare biomarkers. Based on these biomarkers, the gastric cancer can be classified into 2 big categories, either the HER2 positive or HER2 negative. HER2 positive can be further categorized into PD-L1 positive, PD-L1 negative. The HER2 negative can be categorized into PD-L1 positive, Claudin 18 positive, MSI positive, and all negative. And in all negative, you might think about adding a 3rd chemotherapy, which is docetaxel, to the classic doublet of platinum and 5FU. So let's talk about the HER2 negative, PD-L1 positive, metastatic gastric cancer. So what we know so far, that chemotherapy improved the survival and quality of life over best supportive care. Okay, this is what I had been told when I started my medical oncology practice. I never questioned my tutors at that time. Okay? Yeah.
2 years.
So after that, we knew that combination chemotherapy was found to be better than monotherapy. Then we started to adopt the triplet chemotherapy, me, Ashwag, Dr. Sharm. At that time, the ECF generation, they started to adopt that. Then the triplet chemotherapy was put in question, whether it's better than doublet or not, until we had the TAX study, which tested the addition of docetaxel to the 5FU and platinum components. And we found that maybe there is some benefit of adding that taxane to chemotherapy. Oxaliplatin and cisplatin were interchangeable in most clinical trials, although meta-analysis showed that oxaliplatin might be a better option. Capecitabine and fusion and 5FU are interchangeable. Irinotecan also was replaced for oxaliplatin and was found to be equally effective. So this is what we know about chemotherapy alone in metastatic gastric cancer. This is the TAX 325, which I refer to, that adding docetaxel to the doublet of platinum 5FU has improved the overall survival. I have treated very few patients, like maybe 12, 13 years ago with this protocol when it was a hype at that time. But now, actually, in the last year, 2025, there have been a report of another study using much smaller dose of docetaxel of 50 milligram per square meter with a much smaller dose of oxaliplatin, 85 milligram per square meter. So it was much tolerable kind of triplet regimen, which showed to be better than FOLFOX. So this is an attractive option for those patients who don't have any biomarker to be considered to add immunotherapy or monoclonal antibody or anti-HER2 on top of the doublet chemotherapy. You can add the docetaxel with this smaller dose. So these are the three landmark studies talking about addition of immunotherapy on top of doublet chemotherapy. The Checkmate 649, the Rational 305, the Keynote 859. Testing adding nivolumab, pembrolizumab, and tislelizumab. It's hard to talk about all these immunotherapies with all pharmaceutical sitting at the back there, but I can assure you that all of these studies showed improvement in overall survival plus other endpoints like progression-free survival and overall response rates. All of them are acceptable options in PD-L1 positive patients. Specifically talking about MSI positive population, as Dr. Ali mentioned before, in those patients, the immunotherapy alone showed significant benefit in comparison to chemotherapy. This was shown in the Keynote 061, in the Keynote 062, where chemotherapy also was added to Pembro. And chemotherapy addition to Pembro didn't add any extra benefit, though Pembro alone was better than chemotherapy. And also we have seen that in the Checkmate study using the combination of nivolumab and ipilimumab, which showed a superior outcome in comparison to chemotherapy alone. So these three studies, it does tell us that in MSI high patients, you can have a window or a space of using immunotherapy alone without need of adding chemotherapy, specifically for those patients who are not candidate for chemotherapy or who are not willing to go for chemotherapy. And this table summarizes the three different studies, as I mentioned, with all of the outcomes, overall survival, overall response rate, progression-free survival. All of them have been approved on top of doublet chemotherapy, platinum 5-FU, preferably the oxaliplatin when I talk about platinum component. So let's move on to the second category of metastatic gastric cancer, those who have HER2 positive, PD-L1 negative. Okay, we know about the TOGA trial, which have been actually presented, published in 2010. So this was 16 years ago. And since then, we adopted the TOGA approach, adding trastuzumab to 5-FU platinum component because of the improvement in overall survival in these patients. The question, do we have a room for immunotherapy in PD-L1 negative population? This is a study which was presented actually, I think 2 weeks ago, the Horizon GEA-01, testing a new anti-HER2 therapy, the zanidatamab, plus minus tislelizumab, plus the chemotherapy in comparison to the TOGA approach, which is trastuzumab plus chemotherapy. So this is a 3-arm study randomizing HER2 positive gastric cancer, irrespective of PD-L1, into these 3 arms, either the TOGA or the other arm, zanidatamab plus chemotherapy, or zanidatamab plus tislelizumab plus chemotherapy. And the rationale of adding immunotherapy here, they believe that HER2 positive gastric cancer are immunogenic kind of cancer, which can respond to immunotherapy irrespective of PD-L1 testing. This is the comparison of zanidatamab plus tislelizumab plus chemotherapy, the triplet regimen versus TOGA. You can see there is a significant improvement in progression-free survival of almost 4 months with a significant hazard ratio and p-value, as you can see there. And this is the zanidatamab plus chemotherapy in comparison to TOGA. So without the immunotherapy, without the tislelizumab, and you can still see exactly the same kind of benefit with regard to progression-free survival, almost 4 months, absolute difference with exactly similar hazard ratio and p-value. And if you look at the overall survival, once again, there is a significant improvement by almost 7 months in favor of the triplet regimen, zanidatamab plus tisli plus the chemotherapy in comparison to TOGA. But once again, even without the tislelizumab, the zanidatamab plus chemo was superior to TOGA with similar kind of benefit with regard to overall survival. So with regard to toxicity, we can imagine that the triplet regimen had much more added toxicity in comparison to the zani plus chemotherapy in comparison to the TOGA. So the message of this trial that adding tislelizumab did not add extra benefit in comparison to zanidatamab plus chemotherapy, with much added toxicity and, of course, most importantly, financial toxicity. So if you're going to apply this evidence, I think zanidatamab plus chemotherapy in HER2 positive, irrespective of PD-L1 testing, would be the way to go. It's not FDA approved, it was just presented, but probably it's gonna grant an accelerated approval for this indication. This is the Destiny Gastric 04, which I believe Dr. Ahmed Al-Haybi will talk about it in the second line setting. So let's move on to the HER2 positive and PD-L1 positive population. All of us are aware of the keynote 811. Where is Dr. Asham? Is he still resistant to this protocol? Because I remember he was quite resistant applying this protocol in his clinical practice. So what they have tested, adding Pembro to the TOGA approach, whether it would be better than TOGA approach alone in HER2 positive population, again, irrespective of PD-L1, they have tested that. You can see that there was much deeper responses, adding pembrolizumab to trastuzumab and chemotherapy. You can see that overall survival was significantly better with addition of pembrolizumab, and this kind of benefit was maintained for those who are PD-L1 positive with CPS score more than 1. And this is what was the FDA designation of approval of pembrolizumab in HER2 positive cancer population if they are PD-L1 positive or CPS score more than 1. And as you can see, the responses, objective response has improved from 60% to 73% by adding pembrolizumab, which is, I think, a landmark study and a practice changing in HER2 positive metastatic gastric cancer. Then we'll move on to the Claudin 18.2 positive and PD-L1 negative population. And in this regard, we have two landmark studies. One of them is the Spotlight study, testing adding a new monoclonal antibody called zolbetuximab, in addition to chemotherapy versus chemotherapy alone, which was FOLFOX. There was a significant improvement in progression-free survival and overall survival. And the second study is the GLOW study, the same kind of concept, adding zolbetuximab to CAPOX. Chemotherapy has improved the overall survival. As such, the zolbetuximab is considered a standard approach to be added to chemotherapy doublet. A patient was Claudin 18.2 positive and PD-L1 negative. What if we have Claudin 18.2 positive and PD-L1 positive? Can we add both together? The zolbetuximab plus immunotherapy. You remember last year, I had a debate with Dr. Sharif Al-Sammani. I'm defending the IO, Dr. Sharif was defending the zolbetuximab. Finally, I was able to convince Dr. Sharif to go with the immunotherapy. But now I'm looking for some sort of solution between the two of us, at the mid of us. Okay, so there was a phase 2 trial, actually, trying to combine both the zolbetuximab and nivolumab. This is a phase 2 single-arm study, and it showed significant improvement in progression-free survival at 6 months, which had been reported to be 76%. This is huge. And overall survival at 1 year was 76%. This is, again, huge. So this is a very promising approach based on a preliminary phase 2 data. This being now tested in a phase 3 trial called the Lucerna trial. Definitely, we don't have the results yet, but we are really thrilled to see whether this will be reflected in a phase 3 trial, which is adding zolbetuximab plus Pembro in addition to chemotherapy. And finally, once again, this is the ISMO guidelines, which I think is the most practical guideline talking about management of metastatic gastric and esophageal cancer. You have to categorize your patient into HER2 positive, HER2 negative, and according to the subcategories, whether PD-L1 positive, PD-L1 negative, Claudin 18.2, and other biomarkers, you might choose the best chemotherapy combination for your patient. And thank you for your attention.
Thank you, Dr. Ahmed, for elegant presentation and sticking to the time. Now it is my great pleasure to introduce Dr. Ahmed Al-Haybi, who's going to talk about HER2 positive gastric cancer sequence of therapy. The floor is yours, Dr. Ahmed. Go ahead.
Thank you. Assalamu alaikum all. Thank you so much, Mr. Chairman, for the kind introduction. I'd like to extend my thanks and gratitude to Dr. Ashwani and Dr. Mohammed Ghani for the kind invitation, myself for the fourth time or fifth time now enrolled in this prestigious event. So thank you all. And it is a great pleasure actually to give a talk in front of such a wonderful audience. It's very hard to give a good talk after eminent speakers like Dr. Ali Ghahtani with his remarks, and Dr. Ahmed Shahid as well with his wisdom and knowledge. So I was given the task of talking about the HER2 sequences or sequencing of treatment in the metastatic setting. I know that Dr. Ahmed Shahid had stolen a lot of the thunder that I was about to say, but inshallah I'll be able to enlighten some and shed some light on how we should think about such a disease. So in terms of the epidemiology, we all know that majority of the cases we can catch up in the localized or local advanced setting. It is still the third most common leader of cancer death amongst all cancer sites. As you can see here, we see all patients either in localized or local advanced setting. We still see a good chunk of our patients, unfortunately, in the metastatic setting, exceeding about 30 to 40%. There's an excellent, so that's the registry, and you can see it's like ranked number 10, and the age is between 60 to 74. And the higher the age, the more prevalent and the more common the disease that we see in our clinics or in our population. This is an excellent paper that was published by Dr. Ibrahim Al-Ghamdi at the Al-Bahra University. And you can see here very clearly that at the age cutoff more than equal 50 here in Saudi Arabia, it seems that the prevalence would be higher than if it was less than 49. And this also tells us that it is a disease of the elderly more than anything else. So moving on to the first-line treatment in the HER2-positive metastatic gastric cancer, we have the Keynote 811, which was presented brilliantly by Dr. Ahmed Al-Shahri. So we here have the HER2-positive, PD-L1 has to be positive for this regimen to work. We have the chemotherapy trastuzumab versus the experimental arm, which is the pembrolizumab trastuzumab chemotherapy, and there is a median follow-up of almost 50 months. As you can see there, they were mainly stratified based on the PD-L1 status, whether it's negative or positive. And you can see here that there's a difference of almost like 4 months, 20 months in favor for the experimental arm, as opposed to the chemo and trastuzumab arm. And it is very clear here that the curves separate early on, they stay well separated from there on, and which is something that's quite unique to the immunotherapy effect, as you see the effect at the end of the curves. And the responses is still durable, and it is excellent, especially in the CPS more than equal 1. So you have to have a PD-L1 that has to be positive for this regimen to work, with the safety profile almost equivocal between both arms. So it is the first line standard of care in patients with HER2 positive and PD-L1 positive with a CPS more than equal 1. So I remember Dr. Al-Ghahtani had mentioned that we see a lot of patients with CPS positive. I haven't seen any in my clinic, unfortunately, so far, except maybe for one. So I don't know where that 40% came from. So the IO Integra, and I think that's a very important study that we'll talk about that later. I have to mention that. So the Integra study, I think this is an important study. I know that it might seem to be as a negative study, but hold on just for a minute. So the Integra study looked at the 88 patients. It is a phase 2 study. Looked at 88 patients with a gastroadenocarcinoma or gastroesophageal adenocarcinoma. They had 2 main arms. So the first arm is the chemo-free arm. So there is no chemotherapy given in this arm where they had received trastuzumab, nivolumab, along with ipilimumab. So high doses of ipilimumab for 4 cycles, along with the tras and nivolumab for 4 cycles, then the maintenance nivolumab and trastuzumab. The arm B is the standard of care chemotrastuzumab. They had stratified those patients based on age, ECOG, and the primary site of tumor. So you can see here at the 12-month mark, the chemotherapy backbone demonstrated superior survival rates, very clear, 70% versus 57%. And the rapid tumor control was in favor of the chemotherapy arm, as well with the FOLFOX, as opposed to ipilimumab, with an overall response rate, again, in favor of FOLFOX, as opposed to the chemo or the immunotherapy. However, when you look here And I can see that there is a prolonged initial deepening of the curves. So in favor for the chemotherapy as opposed to the immunotherapy. But you can see that later on, the ipilimumab arm would start to pick up and it starts to plateau. And that tends to have shown that there might be some benefit to the overall survival, which is quite strange when you look at that curve. So the final median overall survival was in favor for the chemo-free regimen of 23 months versus 22 months. I know it's not that statistically significant, but something to be kept in mind. So they looked into depth into that. What kind of biomarkers are we missing? Is there something that we need to look at so that we'll be able to choose the patients properly for the treatments? And you can see that about 44% of patients had CPS less than 5, maybe negative, CPS more than equal to 5, maybe about 56%. And you can see that in particularly patients who had a negative CPS or CPS that is low, they gained the most benefit with the chemo-free regimen in the form of nivo-epi. And I think the epi component played a major role in controlling such a disease. You can see that the overall survival is 32 months versus 26 months in favor of the chemo-free regimen as opposed to chemotherapy. However, in patients who had a prolonged or higher CPS, the chemotherapy did better. So it is kind of a twist. We don't exactly understand what's going on there. It is a phase 2 trial, so not a lot of conclusions should be made out of there. However, something to be kept in mind, it seems that the doublet or dual immunotherapy did well in patients with a negative CPS or CPS low as opposed to the higher CPS where chemotherapy did majority of the benefit. So continuing on with the horizon, so Dr. Ahmed Shiri had done an amazing job explaining the horizon. I'm not going to go into depth over it. It's just like a general schema for the phase 1 study, the phase 2 study, and then initially later on the phase 3 study, which I think is going to be going to get an accelerated approval for basically to be starting treatment as soon as possible with these patients. So that's the study design. You can see the trastuzumab chemotherapy versus zanidatamab chemotherapy versus the zanidatamab chemotherapy and the immunotherapy tocilizumab. So how does zanidatamab work? It is a potent dual epitope inhibitor of the HER2. It inhibits the HER2 at 2 different sites, along with the anti-PD-1, which is the tocilizumab, and supposedly it will prevent the T cell infiltration. And then later on, it will lead to more potent action. So moving on to no immunotherapy, again, it's the TOGA trial. I'm not going to spend more time on it. And we all know that it has been, and it still constitutes as a major weapon in our artillery fighting metastatic gastric cancer HER2-positive disease. So moving on to the second line option, which is mainly through the Destiny Gastric 04, and that utilize the use of the T-DXd, the trastuzumab deruxtecan, versus ramucirumab, paclitaxel, and patients who had been previously progressed on other lines of treatments, even including the immune checkpoint inhibitors. So they included those patients with metastatic gastric, esophageal cancer, adenocarcinoma, HER2 positive. However, with the caveat, they needed a biopsy after progression to confirm the HER2 is still there. So it's something that has to be kept in mind. It's not an automatic thing that we just switch and give those patients trastuzumab deruxtecan because they have done that in this trial. So they were randomized into 2 and to 1:1 ratio. The experimental arm with the trastuzumab deruxtecan at a higher dose of the T-DXd of 6.4 milligram per kg IBQ3 weekly versus paclitaxel as per the Rainbow study, stratified based on region, time to progression, less than 6, more than equal 6 months, and the HER2 being +3 versus FISH and +2. So something to be mentioned is that they had majority of these cases with stomach cancer, along with some even brain mets, although small population. So the overall survival was in favor for the experimental arm of the T-DXd, almost 50 months versus 11 months, with the significant hazard ratio, early separation of the curves, and they stay well separated from there on. And the same thing is truthful for the PFS as well, as you can see there. When it comes to overall response rate, it's almost 44% versus 29% in favor of the T-DXd, with a good duration of response, about 8 months, or 7 months, with an excellent disease control rate. So the side effect, the most prominent one is the interstitial lung disease, which occurred in about 14% of patients, as opposed to the other arm. Keep in mind the majority of these cases had a grade 2 toxicity rather than a grade 3 or 4. However, we need to be very vigilant on any respiratory symptoms should these patients mount during any time while being on T-DXd. So again, the implications of this as a standard of care, it is a standard of care in a second-line setting. We always have, I would recommend to obtain a rebiopsy of these patients because the HER2 has been implemented that upon exposure to trastuzumab in the first-line setting, you tend to lose the HER2 in that kind of regard whenever you expose them to another HER2 or anti-HER2 treatment. I'd always monitor for interstitial lung disease. So it is a standard of care now. So when it comes to the third line and beyond, I would say now you have the ramucirumab plus paclitaxel as per the Rainbow study, and you have the REGARD study where the ramucirumab has been given. We all know that the overall survival benefit is there, and we have been practicing that. The same thing is truthful for the TAS-102 through the TAGS and MAX study. There is good overall survival. The TAS-102 was given as opposed to the investigator's choice of chemotherapy as well. So I run across two, I think, potentially excellent studies and potentially practice changing later on should they be proven to be positive. So the first study was the Artemis Gastric 01, which is a phase 3 randomized study that looked at the use of what this molecule called the rilvegostomig, which is quite a mouthful of a molecule to be mentioned. So it is an anti-TGET and anti-PD-1, so it has both domains to be targeted. The TGET target is very important. By the way, it's basically something that has been done in the lung cancer world to make the tumor microenvironment more hot as opposed to keep it as cold. And once you make it hot, more T cell will be infiltrating and the expansion of the T cell regs will be less so that you'll be able to mount good tumor response in these cancers. So always keep that in mind. So they had 3 arms in this particular study. Again, these are patients who had never been treated. So HER2, PD-L1, CPS more than equal to 1, with gastric cancer or GEG cancers. They had 3 arms, the molecule with T-DXd and chemotherapy, or pembrolizumab, trastuzumab, which is the standard of care in the first-line setting, or the molecule trastuzumab and chemotherapy. And the rationale for the T-DXd to be given, because we all know that it has an excellent response to overall survival in second-line setting, so it only makes sense to bring that up in the first-line setting accordingly. And that's their key eligibility criteria, as you can see there. So the last study is the Mahogany study. Again, it's a study that's actively enrolling, and they are evaluating the use of margetuximab. If I'm not mistaken, it's being used in ovarian cancer for any gynae oncologist here, in combination with the HER2 positive molecule as well. So the way it works, it has an active binding to suppress the tumor cold microenvironment and to overstimulate the co-stimulatory signals as well. So it's being given with another molecule, which is an immune checkpoint inhibitor. Again, it is still actively enrolling, and you can expect that such a regimen, especially the chemo-free regimen in the cohort A, is going to be very intriguing, should be able to provide that for our patients in the future. So when it comes to the stomach cancer, the gastric cancer, the HER2 positive setting, that's the NCCN guidelines. There hasn't been much of a change over the past 3 years, except for the addition of pembrolizumab to trastuzumab. How about the subsequent and second-line setting and beyond? You have the ramucirumab paclitaxel, but we all know that T-DXd is the triumphant medication to be given. So every time I think about adenocarcinoma, I have to sort it out in that way. It's exactly as had been mentioned by the MSI has to be looked at, and we have to treat them differently. We do not give them chemotherapy; it has to be immunotherapy. So I totally agree with that point. So when it comes to the HER2 positive MSI low PD-L1 more than equal 1%, first-line setting is the chemotherapy along with the trastuzumab, pembrolizumab, and the subsequent line trastuzumab, T-DXd, and I think this is going to be a lot of branches in the future. And with that, I conclude my presentation. Thank you so much.
Thank you, Dr. Ahmed Al-Haibi, for the excellent presentation. We'll move on to the last lecture of this session. I'm honored to present Dr. Ashwag Al-Hayyan, Medical Oncology Consultant with experience in section of the Medical Oncology National College of Dental. Ashwag, microphone is yours.
So take that. It's there? Okay. Assalamu alaikum. Good morning, everyone. شكرا بقى for the presentation. غياب مو جدا. ثاني شيء أحمد، وين أحمد الشهري؟ ماني دفعته، أنا أصغر منه، أنا دفعة علي وأحمد الهيبي. ما أعرف. طيب. So I was told to give HCC as usual. أنا شكلي بغير last name لل HCC. طبعا I'm sorry for my voice. Had a flu. Anyone I hate, I'm gonna come closer to you today. تمام؟ أنت بقول لي اللي قريبة منه عرف إن أنا ما أحبك. Good. So we're talking about certain things in HCC as like most of the knowledge of HCC very much in the last at least 1 year did not change that much. So we're gonna look at biomarkers, systemic approach, and multidisciplinary care and sequencing of therapy, which is, I think this is probably the most important. So HCC is like any other diseases that we think it is when it comes to oncologists, it's a terminal disease. No, I think it's gonna change. We're talking about adjuvant, which yet not the best, but I think new adjuvant, or we can call it like conversion therapy, I think this is probably the point. Multidisciplinary care or multimodality care, again, I think this is the approach. Why did it fail? Most of the trial of multimodality, I think because the way it was conducted. So if we look at this BCLC, we were only in the advanced C, but now we move to the intermediate, and now we're gonna find us on the early stage as we're talking about the adjuvant treatment, which is, I think, probably it's gonna come, but in a different approach than that we have. This is what we have, like the standard of care in terms of treatment. This is the first, second line options. But when you have more options, that make things more complicated before you have only one option. So you don't even try to discuss with the patient. This is show you each type of treatment in HCC that work differently. Surgery, radiation, or local regional, like we're talking about TACE and TEER, and even TKI and immunotherapy, it's act differently at the cell level. So having one instead of the other, I think probably not all the patients need to have one approach. Each patient should have a unique approach. So if we look at the data for sorafenib and lenvatinib, they are very much similar. Probably it's better in terms of lenvatinib. This is looking at some biomarker that they try to test that favoring using sorafenib or lenvatinib. Again, does come to the clinical practice? No. صوتي واضح؟ This is looking at the second line treatment TKI, which is Rigo, Cabo, and Ramgacimab. If you look at the number, if you look at the Rigo and Cabo are very similar. Reach or Ramgacimab, people I don't think they hate. Anybody use Ramgacimab in HCC? No. Good. I have my fifth patient started two weeks back. So let's see. I put the summary before talking about the clinical trial just to show you that what is the difference between each combination of immunotherapy. I think all the combination, it's great, it have a value, but I think every systemic treatment have its own patient. So let's start with what we're talking about, TKI and immunotherapy. I think the combination between TKI and immunotherapy way better than the dual combination of immunotherapy. Why is that? When they look at the combination of IO plus anti-VEGF or TKI, they have better overall survival. And when they separated these two together, if you look at the curve and at them down the bottom, you see that these combination with the heterogeneity of the drugs, they do way better. So TKI and IO is better than IO-IO. Is it for all the patients? Probably not. Again, this is looking at viral, non-viral. I don't believe in this. So just to see that there is some diversity. You see one combination, they do well with HCV in terms of overall survival, but progression-free survival, no. So it's a lot of confusion. So I don't think the etiology it have a value. So do we believe in biomarker? I think probably not. There is an extensive work done, so we don't have yet a biomarker. This is just an update to the IMPRE. And if you look at the update to the CR in these patients, and most of us, we know that overall response is huge, is around 30%, and also the median overall survival and progression-free survival. So I think atezolizumab, it's one of the best drugs. It have its own limitation and a certain contraindication, which will be very vigilant on that. So patient with a stroke is not a contraindication, but patient with recent MI, you would not use anti-VEGF in these patients have a huge tumor reaching the capsule, risk of bleeding, that's one. But patient with varices is not a contraindication if you can't treat the varices. This is looking at the patient who had confirmed response and overall survival. It did correlate, and you find a patient who had better response, even overall survival did not reach on these patients, whether a RECIST or on modified RECIST criteria. So patients who respond, they do better. And I have patients, they get transplanted on atezolizumab. We have at least 3 patients now. That's looking at time of onset of GI bleeding. That's what most of the people in the other side that dislike atezolizumab, that it's our patient bleed, there is risk of death and so on. So if you look at these patients have all grade of GI bleeding, if you look at the number between patients with varices or no varices, for atezolizumab 24-5, without varices 1-10. More than grade 3 patient with varices, they have the risk of side effect is 20 compared to 5.1. So again, in these patients, you have to be cautious, but again, it's not contraindication. It depends on the grade of the varices. Okay, this is looking at the steroid regimen, the Himalaya. This is the 4 years update. I think you have more than 4 years, 5 years, okay. Yeah, I know that, بس والله ما حطيتها, بس I know إنه في more than 4 years. So again, you can look at the steroid regimen. Again, it's 16. The overall survival compared to 13, and it is similar also for drug as a single agent. And I have to say that we struggle and get trimming in our population, but durvalumab, I think it's extremely excellent drug with 0 side effect. So looking at the overall survival, all the response rate, again, the response rate and the CR was higher in the intention to treat and the long-term survival in these patients are also partial response. And this is looking at 3 and 4 years, which is response overall survival reaching 45 and 37. 36 months was 44% and 48 months was 36%. And we now with the new competition with the Nivo-Epi, which is again coming to the field, they include patients with microvascular invasion, extrahepatic disease, and a high alpha-fetoprotein. And in this combination, if you look at the overall survival, it was 23 compared to 20. And we have to say that the competitor mostly was lenvatinib, and some of the patients have sorafenib. It's the highest in overall survival. And this is looking also to the overall response rate, 36 versus 13, complete response 7, partial was good. And sorry. And if you look at PFS 1 and 2, also it was significant with similar hazard ratio. So I put this again to look why I have choose this or that. So for me, any patient comes with no high risk feature of bleeding, I'm happy to use atezolizumab as the standard of care. Any patient they don't fit to receive like the atezolizumab, they have both combination, which is the Darva, Tremi, or Nivo-Epi. Patient with high volume of the disease, like because we have the best overall response rate on the Nivo-Epi, I might start with Nivo-Epi at the beginning. If you look at toxicity profile, I think the Tremi-Darva, they have the lowest toxicity profile among this. So it will be better tolerance and patient in our aging population. So this is like the way I look for a patient profile when I see patient. Now we have the Torpy as they're trying to put their nose and competing with all these sharks, which is, I think it's not it's a strong immunotherapy to compete with both, but it does show a trend of improvement on PFS compared with sorafenib, and also improvement in overall survival. So we said how we choose between combination, and I think every single oncologist they have their own. كم باقي وقت؟ بطيئة مع المرض. Still have time?
Still 6 minutes.
6 minutes?
7 minutes.
Yes. Okay, so again, we're talking about the more extensive disease using the systemic chemotherapy, but I think there is also a trend of going with systemic therapy in early. I think this is one of excellent trial, but I don't think any one of us adopt this, which is lenvatinib plus TACE, which did show significant overall survival and also significant PFS. If we move to the Emerald, which is looking to the combination of TACE, TERMI, DARVA, and adding TACE to these patients. On this clinical trial, the combination of between DARVA and PIVA and TACE show improvement in PFS and also an overall survival, but not the DARVA alone. So in these cases, if I get a patient with localized disease, would I give the patient DARVA plus TACE? Probably not. Do you think that their inclusion criteria was only intermediate? They include also an early PCLCA. So they do achieve time to progression was higher on the combination of DARVA, VIVA, and TACE compared to TACE alone, but the DARVA plus TACE was not achieved time to progression, but overall response rate was better in the combination than TACE alone. This is the LEAP, which has become a negative trial, so we're not going to discuss it. It have very much similar approach to the Emerald, which is lenvatinib, pembro, and TACE compared to TACE alone. Do I feel this combination? No. And I wouldn't choose any of these combination. Did it give you enough data? I think if they include the right patient, probably it will be encouraging to use it. So the way they divided the patient was totally, for me, not good. So sequencing therapy, I think we have too many trouble now because our patients live longer, not like before. So when your patient progress in immunotherapy, what next? And I think what next? What kind of progression? Is it oligoprogression, systemic progression? Then you can go to second line option of treatment, and you have a local regional option. You have advanced HCC with even meds. If your extrahepatic disease is limited, I think the approach is starting with local regional. It's not wrong. You might start with local regional, then you go with systemic therapy. This is again looking at the tumor PCLC CMP and these patients. We start combination. If the patient did response, we go with local therapy. The way that we do in our center is either one. We start with local therapy, then IO then local therapy. And when the patient responds, they continue therapy. If they have oligometastatic, we'll go with local regional therapy. We hardly get any patient to second line because most of the patients, when go to second line, they did not make it. So adjuvant, we need adjuvant because the recurrence rate is high. We have data for lenvatinib. We have the IMbrave trial, which did not translate it to an overall survival. That's why we don't yet have good data for adjuvant therapy. So they include high-risk patient, but I don't think the data is convincing to start atezobev. So in conclusion, I think neoadjuvant is unmet need because nobody make this in the right way. A liver transplant patient, pre-transplant, local, regional, or even systemic is mandated because that will reduce the risk of recurrence. Strong rationale for adjuvant immunotherapy, but probably we need better trial to address that. Local regional therapy, prolonged survival for BCLC-P, but again, combination of TKI and immunotherapy should be implemented. Thank you.
I would thank you, Dr. Ashwag, for elegant presentation. I would like to thank all our distinguished speakers for their truly outstanding talk. We will now open the floor for questions. I invite all the speakers to the stage. We have like 10 minutes. Any question from the audience? I don't see any online question.
Okay.
Any question?
Then
I would like to ask maybe Dr. Ahmed Shehri. Dr. Ahmed, so now after the presentation of Horizon study, you know, I believe bispecific antibody is the future of oncology. So one molecule hitting two targets.
Yes.
So how do you place the zanidatamab in the landscape of treating HER2 positive? Do you think it is going to replace the Keynote 811 regimen?
Not for now, to be honest with you, because the Keynote 811 has tested in HER2 positive the addition of Pembro plus trastuzumab plus chemotherapy. The zanidatamab study or the Horizon did not test against this control. You see my point? The control arm in the Horizon was the classic TOGA approach, which is trastuzumab plus chemotherapy. All what we can say that for BDL1 negative population, I think the zanidatamab might replace the trastuzumab. In addition to chemo, it might replace the TOGA. But we cannot say that the zanidatamab will replace the Keynote 811. I think it's still the HER2 positive, BDL1 positive population, Keynote 811 will remain the standard of care. But if I have a patient who's HER2 negative, HER2 positive and BDL1 negative, I would rather use the zanidatamab.
Okay, any question?
just one question or something to discuss. We had this kind of debate in our tumor board. So Dr. Ali, when you presented the Matterhorn trial, we know the benefit, we have seen it, it's really great. Now they did include stage 2, which is at least T3. We know FLOT included at least clinical T2. So if you had a patient T2 in 0, would you offer Matterhorn regimen knowing the benefit?
So this is an excellent question, because always when we are seeing T2 in 0 high, low risk, why I would give chemotherapy plus immunotherapy? Because of the fear of patient to be upstaged. So you will, EUS is not an accurate thing. Probably you will end up having, I seen a patient of mine who they said, it's T1. But when the patient went for the surgery and came back, it's more than that. It's even node positive. So these population, I would offer chemo plus immunotherapy and stick with the trial.
Any question from? So let me ask Dr. Ashwag. So for patient atezolizumab ineligible, what would be your default regimen? Do you have preference of like Himalaya stride protocol over checkmate 90W?
هتودينا في داهية يا أحمد. طيب.
From,
It's a good question. No, it's a good question. Yeah. Honestly, if I have like an elderly gentleman or lady I will go with Durva single agent, and it works very well, honestly. If I have a fit and high volume of a disease, that's what I did. I have a 69. His performance status was borderline, but I think because of the disease, he had a high volume on the line. I started Nivo Epi, and I'm just waiting how things will happen. So I think it's per patient. I think each protocol it's have its own good things for the right patient. So if we choose the right regimen for the right patient, I think all the regimen is gonna do well.
Any question?
Just a question to Dr. Ashwag.
Go ahead, Ahmed.
Dr. Ashwag, I know that we have discussed that a lot in several meetings with regard to the etiology, and the liver function capacity, the ALB score. Do you, in your practice, I want to hear your own practice because, mashallah, you have very rich experience in HCC. Would you imply this in your clinical practice, the etiology and the baseline liver function as a predictive marker to use combination?
For etiology, no. For the ALB score, I think the data show that it works, but honestly, it needs a calculation. And I downloaded it on my phone, but I never use it.
It's not easy.
I never use it, honestly. But in general, it's the patient itself. If the patient have an early B, let's say because uncontrolled ascites, but patient not treated, not being diuretic, not being beta blocker, this patient you can downgrade him at least to be 7, so I can treat him. So I think it's variable. Like patient come with a bilirubin of 60, definitely hands off, even if he's young. So I think even the child score, not all similar. And every patient, like the patient I started amlitelimab, he's very young. His bilirubin is around 40. So he's borderline, but his alpha fetoprotein 30,000. So I'm going to give him a chance of amlitelimab and see how things happen.
Thank you. Excuse me, Mr. Chairman, I have a question for Dr. Ashwag. I think you did an amazing presentation, to be honest, especially with the HCC, because it's still very intriguing, even to me, basically. So in light of the new study, the Sierra study, with the durvalumab, they included the high-risk population. Would that not be more intriguing for you to start such a regimen with a dual immunotherapy with only a single dose of tremelimumab, as opposed to the Nivo-Epi with such high doses of tremelimumab, running a risk of adverse events, given in mind that the Checkmate study, they included patients who are quite fit, excellent child view, as opposed to the Sierra?
Ahmed, you hit the right point. Yani, even like the Trimi one single dose, and even we can re-give the dose when the patient shows some progression after a while, at least if it is like long time. I think yes, because we don't have the drug on hand, that's why we have less patient we use. But if I had a patient with a high volume of the disease, I would use Nivo-Epi definitely. And I never saw a pseudo progression in HCC except with Nivo-Epi. All the patients, I treat more than 100 patients in immunotherapy, never see pseudo progression except with Nivo-Epi. So I usually don't change the regimen frequently like others when they see progression, because I do my own assessment. And when I continue, things get better. But in this patient, I stop the treatment and he responded. So yeah.
My question to Dr. Al-Gahmani, you have really done a magnificent job. My question, for like GE junction adenocarcinoma with long-standing dysphagia, they are unfit for triplet chemo. What would be your alternative? Would you go for, Checkmate 577 or Folfox chemo? If Folfox, would you add durvalumab?
So for high-risk population, I'm talking about T4, very high lymph nodes, thinking about systemic diseases high in this patient, I would go with Folfox. I will just omit docetaxel, and I will add durvalumab. I will just modify the Matterhorn kind of style. Now, but here where the cross regimen comes into play. So for these patients with less, I'm talking about, let's say that T3 into, I might consider cross because it is more tolerable than flood. So these are the population I would think about, especially if I can give radical dose of radiation, thinking about like definitive chemoradiation. Those who's not fit gonna be fit for surgery.
Definitely. Any question? I see no questions from online. So we wrap up. I think we can, yeah, I think we close the first session. Thank you for all the speakers for their elegant presentation. We will break maybe for 20 minutes. Dr. Mohammed will announce.
Thank you for all the speakers and moderator for this excellent session. So we're gonna have a break and we'll get back by 10:15. And if you don't mind, if you can come to the podium for a group photo, please.
Assalamu alaikum wa rahmatullah. Thank you all for joining this day 2 of the successful event. Would like to update you that we already shared the registration link, the first registration link of the day, and it was closed already. After this break, we will be sharing the second link. So please make sure to attend and complete your data in order to get the CMEs. Also, we would like to encourage you to have a look at our app where you can register to the second and to the upcoming events. As next week we'll be having a pharmacoeconomic event, and the second week of Feb we will be having a conference about breast cancer. All details are posted in the chat box. Thank you very much. Stay tuned. Assalamu alaikum wa rahmatullah. For any inquiries about the CMEs and registration process, please make sure to visit the link or the event page on the app. You need to register 3 times per day, and you need to be of the targeted population or of the targeted healthcare providers. All information, agenda, YouTube streaming, and all other related information are available on our app. Also, we'll be sharing that on the in the chat box. Thank you all, and we hope to see you in 20 minutes as well. Thank you very much. أعزائنا الحضور الكريم، السلام عليكم ورحمة الله وبركاته. أود إعلامكم بأن جميع البيانات والمعلومات الخاصة بالمؤتمر موجودة على صفحة التطبيق. سوف تجدون كل المعلومات الخاصة بالتارجت أودينس، الفئة المستهدفة. وليكم بالمعلوم أيضا أن رابط التسجيل يتم فتحه لمدة 20 دقيقة فقط من المصدر، وبعد ذلك يتم إغلاقه. فالموضوع يتطلب منكم متابعة في صندوق الدردشة للحصول على اللينك وتعبئة البيانات. شكرا جزيلا لكم.
نورك الاستاذ، حياك الله، يا اهلا بيك، الله يحفظك. Your session. In case Dr. Singham. Yes.
Assalamu alaikum and good morning, everybody. Welcome back to our event today, GIGO Masterclass. So we're going to start our second session for today, which will be about miscellaneous. And our first speaker will be Dr. Saif Al-Thaqafi, who is a consultant radiation oncologist at National Guard Hospital in Riyadh, King Abdulaziz Medical City. He is also the leader for CNS and body radiosurgery program at National Guard. His talk today will be about the role of SBRT in oligometastatic GI cancer. Dr. Saif, the mic is yours.
Okay, assalamu alaikum. Thank you for the nice introductions. Thank you, Dr. Ashwag and Dr. Muhammad, for the invitations. My name is Dr. Thaqafi. I'm a radiation oncologist at National Guard Hospital, Riyadh. So we're going to talk today about the role of SBRT on oligometastatic disease. Let's start with the case to show the role of SBRT on those cases. So this is a 71 years old gentleman who was diagnosed with colon cancer in 2016, T3N1A, KRAS mutated, treated with adjuvant Celox chemotherapy for 8 cycles. After 2 years, he developed this liver lesions, as you can see it here. For that, he was treated with SBRT, 3 fractions of treatments. Then in September 2019, he developed another lesions, which is this lesions here. So the lesion was here. So it was treated again with SBRT, 3 fractions. Or I'm going back. So 5 fractions already treated for that lesions. and the patient showed complete response. This is the MRI of the livers after 6 months from the treatment. So in January 2021, he developed a rib lesion. For that, he was treated again with the SPRT 40 gray 5 fractions. And this is before and after treatment, the PET scan. This lesion was biopsy before the treatment, and after like 9 months from the treatment, he developed what we think is like a lesion on the track of the biopsy, which showed here on the PET scan and in the MRI. And that was treated again with SPRT 30 gray 5 fractions. And this is before and after treatments. After 2 years from that, he developed the lung metastasis. This is this lesions, which was treated again with SPRT for 5 fractions, and this is before and after the treatment. And recently, just in July 2025, he developed a large single metastasis to the brain and found to be also from colorectal origin. He was resected and then giving radiosurgery treatment, 24 gray 3 fractions. And last scan, December 2025, he has no metastasis in the abdomen, no metastasis on the chest. Everything is clean. So this patient from 2018, from the first diagnosis till 2026, was treated with just SPRT. He didn't receive any chemotherapy, and he survived like more than 8 years now with his metastatic disease. So when we discuss or talk about oligometastatic disease, this is the term appeared in 1995 as intermediate stage group between diffuse metastasis and limited disease. Still, the complicated things on oligometastasis is the definition of oligometastasis. So nobody knows, is it up to 3, up to 5? It should be defined based on the each malignancy, or all the malignancy should be defined on the same umbrella by the number or sites, or which site considered to be oligometastasis. So still, this is questions for ongoing research, but most of the trial include up to 5 metastases as a definition for oligometastasis disease. The goal will be, the top goal for oligometastatic treatment is to cure, but if you cannot achieve the cure, then we hope to improve the survival of the patient by doing the SPRT or any kind of local treatment for oligometastasis. And the least of the goals is to improve the quality of life by giving the patient a period of chemotherapy when we treat locally those lesions, and that will improve the quality of life of the patients. So with the more research on the oligometastasis, terms appeared like oligoprogressions, oligorecurrence, and it's become like more being used on the oligometastatic world. So as options, we have the surgical resection, which is the historical options, and is still valid till now to treat the oligometastasis disease. We have the systemic therapy, which is standard of care for all stage 4 disease. And we have local therapy, included the SPRT or RFA, or different ablative procedure like microwave or cryotherapy as well. For the colorectal cancer, I think it is one of the best example for oligometastasis where we can achieve survival. This is like the 10 years survivals after the surgical resections of the liver metastasis, which showed in this trial that's up to 17% achieve 10 years survival, which by definitions in colorectal cancer, it considered as cured, like 17% cured from the metastatic disease to the liver. SPRT is this term we use for precise delivering of radiotherapy usually limited treatment fractions up to 5. It could be up to 8 or 10 fractions, but most of the time it is up to 5 fractions. Usually it is very sophisticated treatment planning, very rapid follow-up. That's mean we save the organ around it because we give very high dose of radiotherapy. So this is just to show you, like before, when we need to treat this area in the middle, we cannot avoid treating the organ on the vicinity, and that's improved. Now we can treat the area we want without treating the organ around, because as I said, we give high dose of radiation, so toxicity will be high for the normal structure. So other synonym term for cyber is SPRT, SRS. This is all the same term for radiosurgery. So what we can do with SPRT, so what organ we can treat? We can treat the liver, the lung, the adrenals, glands, bone metastasis, lymph node metastasis, and also peritoneal metastasis as well. So there is different technique to do the SPRT. What we do in our center is we treat through the cyber knife. So if the organ we treated is movable organ like the lung or the liver, we insert a fiducial on the vicinity of the tumor for the machine to track it during the treatment. So this is through interventional radiology colleague. Percutaneous, it is, I think our colleague published about the complications of the fiducial insertion with very minimal complications after insertion for more than 100 patients they reported on. Then we image the patient. All this happened before we deliver the treatment. So we image the patient with the modality we need to see the tumor, either PET, MRI, CT, whatever we need, we can do it. And this is done before we deliver the treatment. And that's what gives, I think, the advantage of the SPRT after other local treatment like the surgery or the RFA or microwave, where the decision happening during, like when we deliver. But here I can adjust and know beforehand what I'm gonna give to the patient. And as you see here, we recognize all the organ before we deliver the radiation, and we make sure that's like for the liver, it is safely receiving the amount of radiations that allowed. And like here, the esophagus, the stomach, everything is known before we deliver the radiotherapy to the patient. And then at the end, the radiation is delivered. There is a lot of data about, the oligometastatic disease and the role of local therapy, either radiation or other modality. Most of them are retrospective, so I'm going to focus on the key trials on the oligometastasis. One of the key trials is the CyberComet trial. This is multi tumors included on this, including colorectal. 27% of the patient with colorectal cancer, breast and lung and prostate. 1 to 5 metastases randomized between either the standard of care with chemotherapy alone or to give SPRT to the all lesions. And what it showed improvement on the survival and translated in actual 24.6% in improvement in survival. And you can see how's the line here separated. This is in overall survival, and also in the progression-free survival. It is separated widely. And as we can say, 1 in 5 patients included on this trial is cured with cyber. Most of the recurrences, as we know, it is outside the area we treated, so there is like oligo recurrence afterward. And if we compare it with the control group who did not receive the cyber, nobody survived from those patients. Quality of life for the patient receiving cyber was maintained, so there wasn't any determinant like effect of SPRT on those patients. The other new trials, which is just been recently published, So as we know historically, we have one modality is the surgical resection, which wasn't challenged in any trials before. Here, a trial, they challenged this with, this is liver metastasis, 14 center included, lamati-centric, they included patient up to 10 metastases on the liver, 3 centimeters or less. They allowed if like half of the lesion can be RFA'd or microwave, and half of them can be resected to overlap between the two. Good performance status. So 148 patients randomized to surgery, 148 randomized to microwave and RFA. The endpoint, the primary endpoint was overall survival to be not inferior to the surgical resections. And what we found is everything is equal, overall survival, distant metastasis, or local tumor progressions, and progression-free survival. So surgery is equal to microwave ablation for liver metastasis. And what's showed as secondary endpoint is the toxicity. So as you see here, the toxicity in the RFA is around 19%. In the toxicity on the surgical arm is around 46%, which is significantly improved by the microwave ablations. If we look at some numbers, as you see, the serious adverse events in the surgery is more, 20% versus 7%. Lengths of the stay, the median stay with the microwave is 1 day versus 4 days. Local tumor progression is equal between the two arms. So surgery and other modality like microwave ablation is equal for the result and is better on the toxicity for the microwave. This, I think, will change a lot of the standard of care, which we usually offer for the patient as the surgical treatment as the first options. Now it is challenged, and the other local treatment is equally to the surgery. Look at another case here. So this is a 62 years old patient with ascending colon adenocarcinoma, treated with right hemicolectomy in February 2023, T3 and 2, mucinous adenocarcinoma. She's received adjuvant chemotherapy for 6 cycles. Then the patient developed this paraortic lymph nodes in November 2023, treated with SPRT. This is before and this is after. The patient was free of metastasis till December 2024. She had the local recurrence, as you see here on the bed on the colon, which was treated with surgery again with HIPEC. This is done in January 2025. Unfortunately, after that, if you can see here, this is a lesion in the peritoneal, 2 lesions. This is 1 lesion, and this is the other small lesion, which is treated at this time with chemotherapy and immunotherapy. I think cetuximab and encorafenib, I think. And after that, they sent the patient to me, and the patient currently receiving the treatment for this 2 lesion with the SPRT. So this is just to show you there is a lot of retrospective, prospective data on the SAPR oligometastasis of the liver and the lung with all good results. Let's look at another case also here. 45 years old lady with cecal adenocarcinoma, resection 2023, T3 in 1. And the patient received Xelox 8 cycle. During the adjuvant chemotherapy, the patient found to have this liver lesions. So segment 5 lesions here. And this was treated with SPRT, 3 fraction to this area. And this is the after treatment. As you see, that's the radiation effect on the liver after treatment. And the patient last follow-up in November 2025 without any recurrence, so she's free of recurrence and no chemotherapy. This is just to show you that, if we look at different modality of pulmonary oligometastatic disease, metastatectomy surgery versus radiotherapy. This is a just core retrospective analysis, match analysis, and it showed the control rate between the 2 arms is the same at 2 years between the surgery and the SPRT. So if we look at the SPRT as a summary, or the oligometastasis in general, as mentioned before, the definition of oligometastasis till now is not well defined, and it might not be, I mean, till we study each solid malignancy separately. So still, as I said, the cutoff is not known. Some trials now include up to 10 metastases, 8 metastases, 5 metastases, 3 metastases, and some of the trials also limited to some organ like liver or lung, or limited to different patient cohort. Most of the randomized trial included in oligometastasis included in different sites, not just colorectal. This is the collections of all the trial done on the SPRT, on the oligometastasis disease. So there is around 10 trials, 8 of them positive, showed local treatment improve either survival or progression-free survival, and 2 of them were negative, 1 on colorectal, 1 on breast. So if we look at those, trial, the 8 trial, 5 of them were SABR trials. So most of the data for oligometastatic disease came from SABR trials. So 5 of the 8 positive trials were SABR. The last 3, 2 of them allowed radiation to be given, and radiation being given to 75% of those patients. So what I mean is the SABR has the most data to prove its rules on oligometastatic disease. As I show in the trial, SABR can be curative for those patients with oligometastatic disease. SABR is well tolerated. Most of the trials showed no mortality. Morbidity is very low if it's done in a center that treat a lot of patients and well-trained physician. It's cost-effective, and there is multiple trial on the economical perspective of SABR comparing to the surgical resection, which prove the cost-effectiveness of SABR. The advantage on the SABR for the other modality is to treat all the lesion or all the site at the same time. So we can treat multiple, as I showed, we can treat multiple organ with SABR, but other modality like microwave or surgery, sometimes it can be limited on to one organ at a time. And multiple oligometastatic trial showed there is a difference between if you treat some lesion and then afterward treat the other lesions, the result will be less efficacy on the progression-free survival in comparison to if you treat all the lesion at the same time. Timing of the chemotherapy on this treatment scheme, it's not well defined till now to give chemotherapy before for how long, and after we treat with the SABR or any local therapy to give how many chemotherapy or not to give chemotherapy. So that's to be defined in the future. Always I've been talking in my talk with the SPRT about the abscopal effect with immunotherapy, but the reality is most of the trials show limited abscopal effect with immunotherapy on radiation. So in other way, don't count on it. So it's happened to some patient, but the magnitude is not high to be considered as one of the advantages of SABR. So always we need more trial on the oligometastatic disease to define for us better patient and how to treat the patient on those trials in better way. And by that I conclude. Thank you.
Thank you very much, Dr. Saif. We'll leave the question to the end of the session. Now I will hand the mic to my colleague, Dr. Nasser, to present the next speaker.
Thank you. Thank you, Dr. Ali. Thank you, Dr. Saif, for excellent presentation. We'll move for second talk. It's my pleasure to introduce second speaker, Dr. Abrar Zahrani, medical oncology consultant, and also she is the program director of adult medical oncology fellowship at National Guard Hospital, Jeddah. She will speak about GEST, what is the update on adjuvant and on metastatic setting. So, Dr. Abrar, the floor is yours.
Thank you, Assalamu alaikum. Thank you for the great introduction. Thank you for the invitation. I'm honored to be here today. I'll be talking about just tumors. I will go quickly about an overview of just tumor. We'll go talk about what do we know and what do we have about the recent updates or guideline-based treatment in the adjuvant setting as well as in the metastatic stage. And we can also review some of the evolving treatment options that is coming in the horizon. So just to review, it's a rare neoplasm that represented approximately 1 to 2% of primary GI cancers. It's one of the most common mesenchymal or non-epithelial neoplasm of the GI tract. It occurs mainly in older population, median age of 65 to 69 years of age. It can, however, occur in younger children or younger adults, especially that is associated with genetic syndromes. Just have a near universal 95% expression of CD117 antigen. 80% of the just tumor has KIT mutation. 5 to 10% are BDGFRA mutation positive. 10 to 15% what used to call a wild type or mutation negative, or what we call now SDH deficient tumor. Concurrent with the initiation of the first line treatment with imatinib, an assessment of KIT or PDGFR tumor mutation status is advised. So do not wait until you have the NGS. You can start your treatment and then change it as based on the results. Majority of GIST are sporadic. Approximately 5% of GIST have one or several genetic syndrome as primary familial GIST syndrome, neurofibromatosis, and GIST syndrome in pediatric age group. The most common location is stomach, which also carries a good favorable prognosis, 60%. Small intestine is 30%, duodenum and rectum, as well as other disease sites are rare. What about prognostic factors? Tumor size and mitotic rate are crucial. Small tumors with low mitotic rate have similarly good prognosis regardless of the site or location of the tumor, of the primary tumor. They have about 2 to 3% risk of progression to a metastatic disease. Larger tumor with high mitotic rate, there carries high risk for progression to metastatic disease regardless of the primary sites. We're intermediate group with patient with larger tumor, low mitotic rate, or with a high mitotic rate and smaller tumor. Here where the sites can make difference, where stomach has a better prognosis than other disease, and in stomach they have 11 to 15% risk of progression to metastases, where small bowel can up to 50% can progress to metastatic disease in the intermediate risk group. So the primary tumor sites is, as I said, arise with more favorable survival in the stomach more than the other GI tract. Tumor rupture, or some physician will consider it as advanced stage, unfortunately carries the highest risk of progression, independent risk, regardless of the size or the mitotic rate. This is some of the guideline tables to simplify the review of the risk of factors for the progression to metastatic disease. On the left-hand side is the gastric or the stomach, just on the left-hand side, on the right-hand side are the non-gastric. There are also some validated normograms that can be found online where you apply your patient data and information from pathology, and then you can assess risk of metastatic potential. So comes to the next part of this talk, management of localized gastrointestinal stromal tumor. This is just an overview of the NCCN guidelines. If you have a patient with completely resected tumor, you have two things to assess. One is the risk factors of the tumor itself. The other thing is the NGS. Is this patient have imatinib sensitive tumor or not? If your patient has high risk, category as well as imatinib sensitive, then adjuvant imatinib for 3 years is recommended. This is the ESMO guidelines. Again, if you have patient is eligible for upfront resection, and you found that this patient is high risk, adjuvant imatinib is recommended for 36 months. This was based on the following trials. The first trial, this was published in 2014, that assessed adjuvant imatinib for 1 year in patient with tumor 3 centimeter and more, completely resected, versus placebo. There was improvement on relapse-free survival. However, there was no improvement in overall survival. In 2015, they had more specific group, and the publication was of this study looked at patients with intermediate to high risk, just completely resected. This time, imatinib was given for 2 years versus placebo. Again, improvement in relapse-free survival. However, no significant improvement in overall survival. In 2016, the Scandinavian group published what is now the standard of care: high-risk population, completely resected, imatinib 400 milligram daily, 1 year versus 3 years. And this showed significant improvement in relapse as well as overall survival. That's the current standard of care. A follow-up a post-hoc analysis was also reported on this trial at about 10 years follow-up, 10 years follow-up on this trial that showed continued improvement in relapse-free survival as well as recurrence-free survival. And overall survival that was sustained over 10 years. There is a subgroup who did not benefit a lot from the addition of that 3 years: patient with low mitotic rate, patient with KIT exon 9, and patient who had tumor rupture. As we discussed earlier, those patients carry risk group. So despite the extended treatment of 3 years of adjuvant imatinib, at 5 years, the relapse-free survival was 71%, and at 10 years, the relapse-free survival is 52%. So there is around 50% of the population, despite you're treating them with extended course of imatinib, and you're aiming for cure, 50% of them relapse at metastatic disease. This led to the next question: can we extend the treatment more? Would this add more benefits? Well, if we give maybe 6 years, will that improve the survival and decrease the relapse risk? This was the question that was studied in the IMAGEST trial that looked at patients after completion of the first 3 years of imatinib. They stratified the patient or divided patient to receive another 3 years of imatinib versus discontinuation or interruption, surveillance, and then at the time of disease progression, they will reintroduce imatinib. They stratified patients based on the study set as well as risk of just recurrence. So that was part of the stratification, 35 to 70% versus more than 70%, high risk and very high risk group. Looking at the patient characteristics, there was good representation of patients with high risk features like non-gastric, just high mitotic rate, and as well as tumor rupture. There was about 10 patients in each arm group. The risk of relapse about 56%, more than 70, so 60. So around more than 50% in the study population had very high risk of relapse. So the primary endpoint was disease-free survival with a median follow-up of 55 months. In the whole cohort population on this group, like 35, less than 35 to 70, as well as 70% risk, there was benefit of the addition of the extra 3 years. So 6 years showed more improvement in the disease-free survival versus the 3 years. This was mainly seen on the subgroup of 35 to 70%, the high-risk group, with a significant hazard ratio. So the study conclusion was that extending adjuvant imatinib from 3 to 6 years resulted in significant reduction in the risk of recurrence in the whole cohort, especially the 35-70 group. However, a longer follow-up is needed to see if this will also reflect it in overall survival, as this was not seen in this initial population. However, as we know, you can see from, so the time zero, I don't know if I can show it here, time zero here, cannot see it. So time zero here is the time where the two group finished the 3 years treatment. As you can see, 1 to 2 years after the disruption or this connection of the imatinib is the risk of relapse that can be seen. You can see after the 3 extra years of the imatinib, you can see the same curve with the 6 years group. So are we just delaying the inevitable? Are we delaying the relapse instead of just curing the patient? This is one of the theory that we are seeing on this protocol. However, we still need to see a longer follow-up to see what is like the tail of this group, did they actually cure or not? So what about the a very high risk group, patient with more than 70% risk of recurrence or patient with tumor rupture? Well, the disease-free survival was not statistically significant. Could this be due to presence of tumor rupture in this group? If you can see on the right-hand side, the two solid lines represent the patient with very high risk and tumor rupture. So the blue is the treatment interruption group, the red is the treatment continuation group, and patient with tumor rupture. So no matter how much imatinib you give, they will relapse and they have poor disease-free survival benefits from this. So no matter what we do with this group, so that's why some physician will probably treat him as like, or they're behaving like more like advanced disease. And the dotted red group are the patient more than 70% risk of relapse without tumor rupture. So is it the effect that we see here from the tumor rupture group? That's a possibility. This is an update from the Scandinavian study that we discussed, the 3 versus 1 years, looking at the subgroup of the tumor rupture. There was about 20% of the study population had a tumor rupture. They wanted to look and see, is the 3 years making difference in those high-risk group? About 69% of the patients who had tumor rupture, they did not improve their recurrence or relapse-free survival or overall survival versus the other patients who did not have tumor rupture. So the 3-year adjuvant imatinib did not significantly improve the relapse or overall survival compared to 1-year treatment in patients with tumor rupture. Going back to IMAGIST safety profile, as the concern is we're extending treatment from 3 to 6 years. Are we also increasing the risk of side effect? Well, there was no statistically significant difference in the side effect. There was some GI side effect that was seen in the longer group, but both groups had, majority of them had some sort of side effect, 84 in the 3 years and 94 in the percent in the 6 years. Some of the side effect that was seen in the 3 years was related to the withdrawal from imatinib, like muscle cramps and arthralgia, and somewhat with the continuation, like muscle spasm. And myalgia was more with the continuation. Back pain, arthralgia was seen with the disconnection group or discontinuation. Quality of life was not different when was assessed at year, 2 years, and 3 years between the two groups. So for localized GIST, for patients with completely resected primary high-risk GIST with KIT or PDGFRA mutation sensitive to imatinib, adjuvant imatinib with the minimum of 3 years rather than shorter or a surveillance only is recommended. There is emerging evidence now that longer duration of adjuvant imatinib treatment for up to 6 years may provide additional benefits. ESMO guidelines, adjuvant treatment with imatinib 400 milligram daily for 3 years is the standard for patients with high risk. In case of KIT exon 9 mutation, they suggest increasing the dose to 800 milligram or BID dose for 3 years. In patients with BDGFRA D842V mutation, they should not be treated with imatinib. Patient with NF1 related or SDH expression negative, also they are not advising to treat them with adjuvant imatinib. Patient with very high risk of relapse due to tumor rupture at the time of surgery should be offered adjuvant imatinib. R0 surgery is not feasible if R0 is not feasible or implies major sequelae and harbor tumor in patients who harbors tumor sensitive to imatinib. Perioperative treatment with imatinib is standard. The duration is from 6 to 12 months before the surgery, and then continue on the adjuvant part. In case of PDGFRA D842V mutation, neoadjuvant avapritinib may be considered. It's a category 3 recommendation. Now we have completed the adjuvant part and updates on it. Advanced GIST, we're gonna just have a quick review on the guidelines algorithm for treatment and the question that was raised about treatment holiday. Can we stop treatment after a certain time? So this is just a quick look at the guidelines recommendation. So if you have a patient with advanced GIST, I don't know if it's clear on the screen or not, and the patient is sensitive for imatinib, then the recommendation is to start imatinib at 400 milligrams daily, and the patient did not. In the same time, you will be assessing for other NGS targetable treatment. If no response, you have the option to increase to imatinib 400 BID, and then looking for second line sunitinib, regorafenib, And then for patients who are imatinib non-sensitive, as BDGFR D842 mutation avapritinib is also an option in the first line. So initial therapy, imatinib can be initiated in Burkian patient while awaiting the NGS status. In patient with exon 11, the recommended dose is 400, and patient with exon 9 mutation, recommended dose is 400 BID or 800 milligrams daily. What about the dosing? This was based on a trial looking at increasing the dose. Would it increase effectiveness? Increasing the dose did not show any higher efficacy except in patients with exon 9, where the increasing the dose to 800 milligram did show improvement in the progression-free survival in the exon 9 compared to 400 milligrams. So that's where the recommendation for increasing the dose in the exon 9 mutation. What about the consequence of treatment interruption in metastatic GIST who are on imatinib and responding? This was the study question on the BFR14 trial that was initially, the initial publication was in 2010, was immediately after the study was finished recruitment, and then there was another update in 2024. So basically, to simplify the study protocol, they brought patients and they studied them. They gave them imatinib for 1 year, and then they divided the cohort treatment discontinuation versus continuation. The continuation group who went to 3 years, they again divided the group to continue or discontinue, and then also at 5 years remark, continue and discontinue. It's an open label, multi-center phase 3 study. And the primary endpoint was progression-free survival, continuation versus treatment interruption. And secondary endpoint was overall survival, response rate, and to imatinib reintroduction and time to imatinib resistance. I will just be presenting the 2024 endpoints. There is changes from the 2010 initial results. The initial results, it's again showing there is significant progression-free survival benefit with the continuation group versus the interruption group. The median time for progression was 7 months versus 67 months, which was also seen in the initial publication. What was not seen in the initial publication is the significant difference in the time to imatinib resistance, 66 in the interruption group versus 127 in the continuation group, and the overall survival, which was 104 months in the discontinuation group versus 134 months in the continuation group. So discontinuation imatinib did impact the time to resistance as well as overall survival. So it is not recommended as per the guidelines unless there is a side effect of treatment. There was also from the same study, they did exploratory long-term follow-up on the PFR14 trial that was just presented in ASCO last year, looking at overall survival. So the median was 75.3 months. Survival rates was up to 13% in patients at 20 years. They looked at some factor that was associated with better survival. Oh, wow. Okay, I'm trying to be good. Factors like tumor size. The most striking thing was patient with complete response to imatinib and patient who underwent R0 resection did have a very good overall survival, 20 years of more than 12 years. Avapritinib is another first-line treatment indication and patient with BDFR D842 mutant. It's FDA approved based on this phase 1 trial with a significant response rate. So initial therapy, management of advanced metastatic disease, imatinib is the standard of care. KIT exon 9 dosing is higher for PDGFR D842. Avapritinib is the standard of treatment, and medication should be continued until disease progression or intolerance. What about later lines? Sunitinib is approved second-line treatment based on this trial that showed improvement in progression-free survival in the third line. Regorafenib had shown progression-free survival, however, did not show overall survival versus placebo in the third-line setting. Fourth line is ripretinib, which showed improvement in both progression-free survival as well as overall survival in the fourth-line setting. The progression-free survival was good enough that led to another study looking at can we bring ripretinib in the second line instead of fourth line. The study was looking for superiority in the second line setting between ripretinib and sunitinib in progression-free survival. It actually was negative, as the ripretinib did not meet its primary endpoints, with 8.3 months in exon 11 with ripretinib, and sunitinib was 7 months. However, it was not statistically significant. However, we got from data that we get from this study is ripretinib is actually better tolerated this toxicity with a similar progression-free survival. However, it was negative study. There was a baseline ctDNA exploratory analysis that was done on this study, looking at KIT exon 11 plus 17 and 18. Actually, this group did show significant benefits. It is a subgroup analysis with a median progression-free survival with the ripretinib 14.2 months versus 1.5 months in sunitinib, with a hazard ratio of 0.22. The entry trial this finding from the entry trial led to the upcoming side effect, led to the INSIGHT, which is a phase 3 trial looking at that exact population group and treatment with ripretinib versus sunitinib in patients with exon 11 plus 17, 18, with ripretinib show significant benefit over sunitinib in the second line. This is we're awaiting the results for this trial. Other upcoming trial looking at a PEAK trial that was part 1 was presented ASCO of 2024. The randomization study looked in the second line patient with this versus sunitinib. And we are still awaiting for the final results of this study, but an initial result Another study that looked at this exact combination in later line, not in second line, in patients who progressed on sunitinib with bezo plus sunitinib in patients who progressed on sunitinib. So we're also awaiting final results on this study group. Another novel drug is IDRX42. It's a highly selective oral KIT TKI with a broad preclinical activity that is also undergoing investigation with a strategic trial. This is a phase 1 trial that looking at multiple lines, first line, second line, as well as third line. And there was the initial data was also presented in 2024. As you can see, majority of the patient has multiple or heavily pretreated with more than 4 lines of treatment. With a median duration of treatment on this novel treatment, 6.6 months of like fourth line and beyond. Patient, there are promising response on this drug. Patient on second line had objective response rate of 53%. Patient third line or beyond had objective response rate of 24%. The durable or progression-free survival was 9 months in patients who are treated third or more lines. So it will be interesting to know the final results from this study. So just summary of the later lines, management of advanced metastatic disease after progression on imatinib will be still the standard of care is sunitinib in the second line. Third line is regorafenib, ripretinib in the fourth line. However, just stay tuned, this might change soon. And with that, I conclude my presentation. Thank you very much.
Thank you very much, Dr. Abrar, for excellent review for guest. Without further delay, we'll move for the third speaker. It's my great pleasure to introduce Dr. Mohammed Al-Garni, Medical Oncology Consultant at King Abdulaziz Medical City, National Guard Hospital, Riyadh. He will speak about neuroendocrine tumor, overview and update. So, Dr. Mohammed, the floor is yours.
Okay, thank you very much, Dr. for the kind introduction. So I'm going to talk about the gastroenteropancreatic neuroendocrine tumor, just have an overview and some updates. This is the outline of my talk. So looking to some of the epidemiological data, we have noticed that there has been an increase in the incidence of the neuroendocrine tumor over the last 4 decades. This is mainly contributed to more of advancing diagnostic modality, and we are doing more imaging for other indications, and sometimes we discover this tumors. Still, 40% of those patients present with advanced stage, And as you know, the prognosis is variable depending on the tumor site and the grade and the stage. So when it comes to the classification, one of the most important prognostic factor is the grade of the tumor. So in gastroenteropancreatic neuroendocrine neoplasm, the tumor differentiation is important, the grade of the tumor is important, and we have recently incorporated the neuroendocrine tumor grade 3 that historically can be classified as a neuroendocrine or a high-grade neuroendocrine tumor. But it's a distinct type of neuroendocrine tumor, which is still well differentiated, but with a high grade. And this also raised the challenge about the best and optimal management of those patients. This is to the reflection of the differentiation of the tumor. So when you have neuroendocrine tumor, grade 1, grade 2, even with grade 3, well differentiated neuroendocrine tumor, the survival is good. If you have patient with neuroendocrine carcinoma, which represent about 20% of all cases, the prognosis is really bad, and it's very aggressive type of tumor where the only option of treatment is conventional chemotherapy. So there are multiple singularities related to neuroendocrine tumor. As you know, we have wide anatomical distribution, the spectrum and the behavior of the tumor is variable. Although some of them are indolent, but they still can metastasize and can affect the organ function. Sometimes can be associated with hormonal hypersecretion, which is related to the functional neuroendocrine tumor. And we know that among patients with well-differentiated neuroendocrine tumor, most of them, they express the somatostatin receptor. And we know that the common symptoms are related to the serotonin release, or what we call the carcinoid syndrome, which happens typically in patients with small bowel neuroendocrine tumor and in patients with lung neuroendocrine tumor. The symptoms variable from flushing to secretory diarrhea to sometimes life-threatening carcinoid crisis. Also, neuroendocrine tumor can present in a syndromatic picture. So we have the Zollinger-Ellison syndrome, for example, a patient with gastrin-producing tumor. Those patients also sometimes they can present with some skin manifestation, like those with glucagon hypersecretion. They can present with typical migratory necrolytic erythema. So systemic physical examination for those patients and hormone function assessment is very important part of the disease assessment. And when it comes to the management of neuroendocrine tumor, it's a multidisciplinary approach. So the oncologists play a role on this. However, the good pathology with experience in neuroendocrine tumor, the endocrinologist to help with the hormonal hypersecretion. Also, you need a good gastroenterologist and surgery as well for those patients who might require debulking surgeries. And these are the factors that we take into account when we decide about managing patients with neuroendocrine tumor. So the tumor burden is important, the Ki-67 and the rate of progression. So the tumor kinetic is very important. And sometimes it needs some time to see how the tumor progresses. So if you have someone with a high disease volume and with a higher Ki-67, you are moving more towards systemic therapy in form of chemotherapy or PRRT. But if you have slow kinetic tumor or very low Ki-67, still there is a room for somatostatin analog. In addition to the role of somatostatin as a symptomatic treatment for carcinoid tumor, it has anti-proliferative effect. So we have two agents, the octreotide and the lanreotide. It has been studied in two famous trials, the PROMET for the octreotide and the clarinet for the lanreotide. There are some differences included in these studies. So pancreatic neuroendocrine tumor was excluded in the PROMET study. There are more heterogeneous population in the clarinet study, and they allow Ki-67 up to 10%. And both studies actually showed improvement in the progression-free survival, and both are being used and part of the standard of care for patients with well-differentiated grade 1 or 2 neuroendocrine tumor. These are the data of the progression-free survival. As I have mentioned, it's positive in both studies. So another form of targeting the somatostatin receptor is the development of ligand specific treatment. So we have the understanding of the somatostatin receptor role help in the diagnosis. So we have the gallium dotatate scan that can help you to know the staging and the expression of somatostatin. And the implication of this is the therapeutic use of lutetium on patients with metastatic neuroendocrine tumor. The first study that has shown the efficacy of the PRRT therapy was the NITTER-1 trial, which looked to PRRT as a subsequent line of therapy. So they included midgut with Ki-67 less than 20%, and they included functional and non-functional neuroendocrine tumor, and they compared it to high dose of ectreotide, and the study was positive of the with the median progression-free survival reached up to 28.4 months in the favor of PRRT therapy. So this has also changed the practice and brought the PRRT as a standard of care for patients with well-differentiated neuroendocrine tumor who progressed on somatostatin analog in the first month. Then we have the NITTER-2 trial, which is moving the PRRT therapy to the first line. So they included more of heterogeneous group in this study. They allowed even grade 3 neuroendocrine tumor to be enrolled in this study. And as you can see, there was a significant improvement in the progression-free survival, which was the primary endpoint of the study. And it was also associated with improvement of the overall response rate. So the PRRT therapy arm, the overall response rate was 44%. And if you look to the subgroup analysis, both grade 2 and grade 3, they derive the benefit from the PRRT therapy. So this is just to summarize the comparison between these two studies. However, we have more target other than the somatostatin receptor. So the angiogenesis pathway is very important pathway in patient with neuroendocrine tumor. We know these tumor are hypervascular tumor, and targeting this pathway through different mechanisms might have a positive impact. So sunitinib was one of the studies that one of the drugs that has been used in a patient with pancreatic neuroendocrine tumor. It showed superiority or improvement in the progression-free survival and overall survival compared to placebo. Another agent that has been used and it's recently approved by the FDA for use in neuroendocrine tumor is the cabozantinib, which was studied in pancreatic neuroendocrine tumor and non-pancreatic neuroendocrine tumor. The dose is 60 milligram daily, and the study showed positivity of the tumor and improvement in the progression-free survival in patients with pancreatic and extrapancreatic neuroendocrine tumor as a second-line treatment. Specific population, which is the VHL disease. So targeting the VHL gene with belzutifan, which has been studied in the LightSpark trial that included different tumor sites, not only patient with neuroendocrine tumor. So VHL disease, typically they have multiple tumor, not only pancreatic neuroendocrine tumor. So in the study of the belzutifan, there was 22 patients who have also pancreatic neuroendocrine tumor. And one of the best overall response rate was achieved in patients with VHL-associated pancreatic neuroendocrine tumor. So in those patients, the response rate was almost 91%, and 18% of those patients achieved complete response to belzutifan. So definitely it's one of the options for patients with VHL-associated pancreatic neuroendocrine tumor. Other pathway included is the mTOR pathway, which has implication in patients with neuroendocrine tumor. We know that two studies that looked to the role of everolimus as a subsequent therapy in the RADIANT-3. This is specifically done for pancreatic neuroendocrine tumor. The RADIANT-4 was done for extrapancreatic neuroendocrine tumor. And as you can see, the outcome in favor of everolimus in terms of superiority of progression-free survival. However, we don't expect to see major response rate with this drug, either sunitinib or everolimus. So in this study, the response rate was 5%. Chemotherapy in this setting, we have old chemotherapy. STZ was studied in different studies, and it has been standard for some time. Until recently, we have implemented the temozolomide and capecitabine as one of the standard of care if you are going to use chemotherapy in a patient with grade 2 or grade 3 neuroendocrine tumor. And it's usually associated with better response if the patient has MGMT hyperinflation. But this brings us to the important question. So what would be the optimal sequence for patient with neuroendocrine tumor? Now, since the PRRT is moving to the first line, can we have an optimal sequence for patient? I think this question still needs to be addressed. However, there has been multiple studies that trying to look to this. One of them is the equilorandom trial that looked to the role of PRRT versus sunitinib in pancreatic neuroendocrine tumor. And in this study, they found that the PFS was in favor of PRRT therapy, but it's not necessarily related to the overall survival. Another study that done specifically for pancreatic neuroendocrine tumor is the sector trial, which looked to, if you start with everolimus followed by chemotherapy or chemotherapy followed by everolimus, actually there is no difference. So if you can look to the PFS, it's almost the same. You might achieve better response rate by having the capecitabine or chemotherapy before everolimus, but in terms of progression-free survival or overall survival, there is no major difference. This also study that looked, which the complete trial, which looked to comparison between the lutetium versus everolimus, and they included patients with well-differentiated non-functional gastroenteropancreatic neuroendocrine tumor and pancreatic neuroendocrine tumor as well. And as you can see, the progression-free survival was in favor of the PRRT therapy. But again, we are comparing to the drugs that we know that they have no major overall response rate. So these are some of the summary of the trial that are ongoing, trying to address this question about what is the optimal sequence. And as you can see, the PRRT therapy is a part of all these trials. So maybe in the future, we can have better understanding about the best sequence of therapy in patients with neuroendocrine tumor. These are the guidelines. I think it's going to change soon. This is the last updated guideline from ESMO in 2020, but I think we're going to see some changes like incorporating the cabozantinib as a part of the trial or the algorithm. I think also PRRT therapy is going to move to earlier lines of therapy. So to summarize, I think neuroendocrine tumor is a heterogeneous group of disease. There are increasing incidence and concern, and prognosis is dependent on the stage, grade, and the primary tumor sites. Well-differentiated tumor express somatostatin receptor and can produce hormone, and these are the functional neuroendocrine tumor. Systemic treatment options are increasing. So this is the list of the medication that we already have discussed. I think the question about the optimal sequence and integration of therapy is a matter of debate. And still we have to get more predictive markers to be used as we are moving in the era of precision oncology beyond the somatostatin receptors, which are still a major pending issue. And by this, I conclude. Thank you very much.
Thank you very much, Dr. Muhammad, for this excellent presentation. I would like to ask our distinguished speaker to join the podium for taking questions from the audience. Okay, so maybe I will start the first question to Dr. Saif. So you mentioned in your presentation that SBRT or cyber can be given for any tumor site metastasis. My question regarding peritoneal metastasis. as you know that sometimes it's difficult to localize the peritoneal disease as you the one you see in the CT or PET scan, it's not really reflected on the actual burden of peritoneal disease. Will you take this into consideration when treating peritoneal metastasis, or do you have any other approach?
For the peritoneum, it is a tricky site, so it depends. I mean, as you know, the peritoneum is a big area, so it depends on the location. So in the periphery of the peritoneal, this is can allow us to give the treatment. But if it is in the middle of the bowel, like surrounded by the small bowel, this is cannot be done. So as a case, I showed it was in the periphery of the peritoneal, so that's allow us to give the radiotherapy. But it is an option, but not to all the lesion.
Okay. So, Dr. Nasser, question, please.
I have a question for Dr. Muhammad regarding high burden disease, neuroendocrine tumor. Is there any difference between symptomatic and asymptomatic patients in choosing the treatment or to start the treatment or not?
Thank you, Dr. Nasser. I think one of the major goals in treating neuroendocrine tumor is to control symptoms. However, also we need to take into account the other factor like the grade of the tumor and the primary site of the tumor. So for grade 1 neuroendocrine tumor, still you would go with the somatostatin analog, and good percentage of patients, they will have a better improvement in their symptoms. We also should consider and also keep in consideration always the role of debulking in patients who are quite symptomatic related to significant burden of disease. Always consider surgical oncology evaluation for those patients.
So, Dr. Ahmed Zahrani.
The question to Dr. Mohammed Al-Garni. So if you are faced with locally advanced pancreatic NET, well differentiated, unresectable with liver limited disease that is resectable for conversion strategy, if you have access to BRRT and definitely chemo, what would be your optimal or default option, BRRT or chemo, CAP-10 for downstaging?
So again, we are looking here for response rate in this scenario. So I would, if it's grade 2 or 3, I think BRRT therapy achieved the overall response rate more than 40%. So I would go with the PRRT therapy in this scenario. Capecitabine and temozolomide, again, it's a very reasonable option. But I would go with PRRT since there is a very good chance of response to a PRRT therapy.
Is there any concern about long-term effect for PRRT in first line, especially when giving first line?
Yes, definitely. Again, some of the long-term side effect, and actually it was reported in the NITVER trial, is the myelodysplastic syndrome in some patients. But I think the risk is very small compared to benefit, especially when we talk about conversion or we are hoping to downstage the patient. So it's very small risk, but it's worth offering to the patient.
Okay. Dr. Abrar, one question regarding GIST tumor. So at your current practice, any patient that will may be treated with extended duration for adjuvant imatinib?
I didn't have any patient yet to have the extended treatment, but as I said, we don't have overall survival benefits. Yes, the toxicity was the same and toxicity profile, but I guess I will still go with the 3 years mark, and then probably after the 3 years, we'll see what happens with the patient, if they want to continue or not. But for now, yes, we see some with the 35 to 70%, they have significant improvement. The other groups, very high risk didn't have a difference. It's the question, honestly, not about those group, it's the question about the tumor rupture. What do we do with them? I guess that's the question on everyone. No matter what do you do, there's no improvement in survival. I guess it's, or relapse-free survival. I guess the answer might be a new drug, but so far we only have imatinib. So for those patients, I will continue the treatment for 3 years, and then I probably not.
Yeah, I think what we are facing in the clinical practice, after stopping 3 years, we see a lot of recurrences. So I think maybe in the future, we'll see that the extended duration will be.
Which we also saw even like at 2 to 3 years after the discontinuation of treatment, either the 3 years or the 6 years, we see the drop in the curve. But again, the answer will be hopefully when we see the longer follow-up on the trial.
Okay, I think we reached to the end of this session. Thank you everybody for joining us. Thanks for our distinguished speaker, and special thanks to the organizing committee for the great invitation and organization of this meeting. So I think move now to the satellite.
So now we'll move to the satellite symposium. It's PMS satellite symposium. I think Dr. Al Qahtani and Dr. Ahmed Al-Shehri will be running this session. So Dr. Ahmed Al-Shehri.
Assalamu alaikum wa rahmatullahi wa barakatuh. This is the Satellite Symposium sponsored by BMS. Thank you, BMS, for the kind invitation to moderate this session to talk about the management of metastatic HCC. The title is Deep Dive in the Management of Metastatic HCC, which is going to be presented by Dr. Ali Al-Qahtani, consultant GI medical oncologist at the King Faisal Specialized Hospital and Research Center in Riyadh. So, Dr. Ali, I remember Dr. Ali last year, you had a debate with Dr. Kanaan Al-Shammal, but you were defending the Nivo EP at that time.
Yes, so
Okay, so you are standing at the same position.
Yes.
طيب.
نشوف امورنا لسه. لا قدرت أقول. طيب دكتور احمد عندي طلب. صح ان بي ام اس ساتلايت سيمبوزيوم وسبونسرد وكذا لكن feel free to raise the discussion to all limits. Okay, so we'll have open discussion, kind of advisory board situation. خلاص? So first of all, let's admit that HCC is keep increasing. And the problem is, despite that the rate of HCC and BTCs are increasing, mortality is still going up. We have more treatment option, but still our survival is not the best. Now, this is, if you look at countries and incidence globally, it's keep increasing, as well as mortality the same day. Now, we are fortunate enough, at least in our region, we don't have much of HCCs cases similar to what we are seeing or observing in the Asian population. But metabolic dysfunction associated steatohepatitis is now the etiology. In fact, I had a meeting last week running some of our data at King Faisal, and we noted that almost 50% of the cases nowadays are metabolic causes, not even hepatitis situation. So it's so Allah yarham والديكم امسحوا hunger station وتمشي هذه كلها متفقات. طيب evolution of HCC treatment. Back in the days, هذا الأيام الله كبير يعني. So it was best supportive care, no more treatment. But thanks God, look at this. We have so many treatment options in the localized setting, intermediate setting, metastatic setting. In fact, we are starting now talking about combining sequencing in the intermediate stage or even systemic therapy at home. Now, the timeline of treatment of Google Frontline, really what started out is 2007, which is sorafenib. Then we waited for 10 years, we got the Lenvatinib based on Reflex. Then 2020, IO was first proved to be effective, at least in the first line. We do have Nivo and pembrolizumab been tested out in the second line. But let's stop here. 2007 till 2018. Why we did not have any approval? And the fact is, what was the problem is how we are selecting our patients in these clinical trials. So reserving these patients or these agents to only with good functional status as well as good liver function test was the key For that, we start seeing all of these approvals. So TCAR probably worked a long time ago, but was not been approved because of the liver. So good liver function, good outcome. Now, let me go back a little bit here. So atezolizumab approved to be effective in 2020, but then took us a few years to say, you know what, we don't need anti-VEGF. Maybe we just do dual IO, and that was the Himalaya study. But most recently, we do have another dual IO agents like nivolumab in this situation. So 2007, we are talking about 3 months delta comparing sorafenib versus placebo, and this is mean overall survival of 10 months in the frontline setting. Lenvatinib was in 2018, and here we are talking about numerically higher median overall survival, but also better objective response rate and side effect profile much better. But then in brain, atezolizumab combination, and most of us been using that, and it's an advanced setting, no prior systemic therapy, but they require AGD because of the varices. And they stratified patient with the region, performance status, macrovascular patient, and baseline anti-beta-protein. And they had atezolizumab in an arm and sorafenib on the other arm, and the primary endpoint was PFS and OS as co-primary endpoints. Now, they included all patients in terms of BCLC staging, but the majority were C patients. Yes, for the first time, we are talking about tail of the curve, 19 months versus 13 months, and improvement in BFS of 6.8 versus 4.3 with good hazard ratio. Now, we are seeing for the first time good responses, a CR of 30%, compared to sorafenib only 11%, and sorry, CR of 8%, but objective response rate of 30%, which is good. Tells you that IO does work in this situation. But then we had this debate, etiology. We started out after the embryo. Looking at hepatitis, you will see that all of them benefit, but the non-viral etiology did not have any benefit, at least from this subgroup analysis. Toxicity. Overall, you are talking about toxicity related to proteinuria, increased hypertension, as well as infusion-related reactions. But sorafenib is sorafenib, you see more of Hanford syndrome, etc., and diarrhea. Toxicity. People feel comfortable with atezolizumab, not because of the toxicity profile, but because we are got used to deal with all of this toxicity. Although you will see the lead discontinuation is 22% of either component, either atezo or bevacizumab. Grade 3 for toxicity, we are talking about 42%. But in reality, most of these toxicity, we know as physicians how to manage with them in general. But welcome to the combination of CTLA-4 and PD-1, PD-L1 inhibitor. So priming the T cell and cap it with the effect of PD-1 and PD-L1. And thanks to the Himalaya protocol, we have an idea about what is it. So in Himalaya, they had 3 arms. An arm where they have a strong regimen, which is 300 milligram plus durvalumab, and an arm of durvalumab alone, and an arm as a comparator was sorafenib. They closed an arm similar to the EPI, which is 75, which is, I think it wasn't a good idea. Maybe we would have some result, a good result from this arm. Now, the primary objective was to see superiority of the stride regimen compared to sorafenib or durvalumab, non-inferior to sorafenib. And we did achieve that. Overall survival is 16 months versus sorafenib 13 months. Remember, the original sorafenib is 10 months. Here it's keep improving. Here is 13 months as a control arm. But in general, we have a hazard ratio of 0.78. Now, viral etiology doesn't matter here. Non-viral etiology, they did have benefits from the combination of IO, and no matter what is the PD-L1 expression. Now, if you look at the stride itself and durvalumab, so median is the same. However, if you look at 24 months and beyond, you will see that the separation of the curve between the stride and durval. So if you take it by number, there was no difference in numbers in terms of survival between adding a single agent of tremelimumab. Now, the issue is the PFS, and I think it's concerning most of us. But if you think about it, most of the PFS in dual IO agents kind of facing the same problem here. There are a subset of patients that they derive no benefit from IO. So what deriving all of this, or the overall survival, is the long-term survival that we are seeing. And this is the 5 years overall updated survival from the start. And you see the clear separation of the curve. And at the end, in fact, there is the 6 years follow-up. And that's what I like about the IO agent, they follow up patients. Remember, the every 150, all what we have is 15 months follow-up. So most of the data that we have after the every 150 are post-hoc analysis in general. Now, objective response rate wasn't the best. It's less than what we are seeing in NMRAVE, or we are seeing later on in the NIVO-AP. Here is 20%. In fact, DORFA has similar performance. We're talking about 70%. But those who respond either as a complete response or partial response, majority of them, they had long-term response, more than 48 months. So this is great. So if I have a patient with IO or an IO, they responded, I know that for a fact they might be long-term survivors. But we have now NIVO-AP versus lenvatinib or sorafenib, the checkmate 90W. So let's go back to the design here. So they included similar design, or they did similar design to other frontline setting situation, unresectable HCC. They had Child-Pugh score good, equal performance status has to be good, but they included no main portal vein thrombosis, and the etiology was stratified as well as MVI as well as AFP. So they have a good number of patients. Here, talking about 668 patients randomized to NIVO-AP versus sorafenib. For the first time, we have lenvatinib as a comparator. 85% of the patients were on lenvatinib, and 15% only were on sorafenib. And remember, here is the AP is 3 milligram per kg, and it has to up to 4 cycles. So they do not mandate that all patient has to get the 4 cycles. In fact, in the clinical trial, not all of them got the 4 cycles. The primary endpoint was overall survival. But you might be asking, why 3 milligram per kg? And it is all based on the checkmate 040 when they looked at the both cohorts, those who got AP 1 milligram or AP 3, and there was doubling of the median overall survival. So it makes sense to proceed with in the phase 3 clinical trial with the 3 milligram per kg. 65 and above. I need you to focus on this because I hear that all the time. We should include only younger patients, fit patients to get that. But there are 52% of this clinical trial above 65. Now, they included all patients, depends on the region, Asian, North America, and the rest of the world. Now, PCLC staging, 73% were they stage C. And AFP was above 400, was 32. Remember, 42% had local regional therapy prior to that, similar to the other clinical trials. Overall survival. And this is for the first time we are hitting 23 months in terms of median overall survival compared to lenvatinib of 20 months and has a ratio of 0.78. But to be honest, I don't care about median overall survival in IO clinical trials because you are thinking about long-term survival in these populations. Now, if you look at overall survival subgroup, even those above 65 years old, they derive similar benefit compared to those less than 65. Etiology did not matter, and we are talking here about baseline AFP. Those with higher AFP, they derive more responses or at least overall survival. Talking about responses, and here we are talking about 36%. In general, I remember Dr. Ashwar was talking about if I want a response, I would go with NIVO-AP, which makes sense. But what makes sense too is the median time to response. Here we are talking about 2.2. I hear people thinking that maybe if I give atezolizumab in this situation, I might get a quicker response. In fact, dual IO agent like NIVO-AP has quick time to response. Here is 2.2. Now, the duration of response is important. For the first time, we are talking about 30 months. In fact, not even double, we are talking about triple what we are seeing with lymphatic, not even sorafenib. So this is a good thing. Now, progression-free survival. Similar situation, but to less extent to what we see in the slide. You will see that there are patients that might not benefit from dual IO, and you will see that the sorafenib or lenvatinib will perform better. However, at the mark of 18 months, you will see the clear separation of the curve favoring IO agents. So treatment-related adverse events. You want response, you want median overall survival, probably will deal with more side effects. And in fact, here, the grade 3 for toxicity, we are talking about 28%. In fact, there were 4 patients, or 4% of the patients, talking about 12 patients died, and majority of them IO-related toxicity. I'll go deeper into the IO-related toxicity and what's going on, but you will see that majority of the cases are hepatitis kind of thing, to less extent, hypothyroidism and rash, as well as hyperthyroidism. Deterioration. Now, we care about the symptoms, and so you will see that the deterioration happens at the beginning, kind of overlapping in terms of symptoms. But later on, you will see that all of this curve is kind of separating, favoring the dual IO agents. Similar to what we are seeing, the fact have total score in the beginning of the treatment, because you are giving the patient 2 agents, and you anticipated that all of these side effects in the beginning. But later on, you will see that majority of the patient, they derived change in positive way, fact had total score compared to lymphatic. So let's go into more updates here, and I'll get you an update from ASCO this year. But you'll see Nivo-Epi in the Barcelona 2024, ESMO GI, as well as from the ASCO last year. Objective response rate, 60 or 36%, CR is 70%. Look at the right here, you will see that responses are good. We are talking about 37%. They will have more than 50% reduction in the sum of the size of these metastatic lesions or advanced lesions. Now, 18% they will get it more than 50%, I would say, or 18% they will get more than 75% reduction. Again, time to response is 2.2 months, and the duration of response is 30 months. In IO agents or IO clinical trials, you think about later on progression-free survival, and Ahmed Zahrani, you like BFS too, and here it did help. So as we are seeing here, 19 months versus 15 months, although the BFS itself, it was no different. Treatment adverse events. Yes, we talked about adverse events, mainly immune-mediated hepatitis, but you will see that most of them are labs related, and I'll show you later on when it should be started and when it's going to be resolved. So hepatitis in terms of lab AST, ALT, all of us, we are not very heavily treating patients, especially as a GI oncologist with IO. So we'll freak out if we are seeing AST and ALT jumping here and there. But if you look, it is in the first 6 weeks, but then it's usually resolved by week 10, definitely following the algorithm like giving steroids and all sorts of things. Let's look at the 4 years follow-up of checkmate 90W. So atezolizumab is a great regimen, and we use it in a lot of time. But I think one of the mistakes that they did not follow up patients beyond 15 months. So we don't have a lot of these data, except STRIDE, and we are seeing here checkmate 90W. We are seeing 4 years and 6 years in the STRIDE. So this is a great thing to see. Now, what we are seeing is maintain the same objective response rate. Median overall survival is the same, 23.7. And we are talking about more and more responses at the mark of 5 years. So we are talking about 31% versus 18% in the lymphatic arm. Now, safety summary, no new signals of safety that happen for those with long-term survival. So bottom line, you will see my side effect in the beginning, but usually if it's resolved or you don't see it, you will not face it, or at least minimal chance that you will see more side effects at the long term. Immune-mediated hepatitis happened, and we are talking here grade 3 for toxicity. We are talking about 15%. 70% of them received high dose, and 6 of them they had discontinuation because of the treatment. First shot in HCC counts. الوالد ما ينصحني واجد، بس دائما يقول لي يا ولدي العود من اول رقصه. هذه نصيحته دائما، نصيحه كمبانيه شويه. ولكن it's mean what you're gonna start with is gonna make difference. And I totally agree. Majority of our patients, they don't do well in the second line. I don't see patients getting lymphadenum and stay on it for years. So what matters is the frontline setting. But definitely cost, side effects, liver function test. And I remember you were talking to Dr. Ashwag about LV score. I think LV score is something that we should consider. Now it's an easy calculation, by the way, just an albumin and bilirubin, so it's not a big problem. Performance status, disease burden. How I choose first line? I think there is a room for all 3 regimens. I'm talking about atezolizumab, nivo-ipi, and maybe in the discussion we'll have it, and as well as for trimidor. But let's look at them side by side. You will see all of them are phase 3, most of them the same eligibility criteria, except in the Himalaya and the Checkmate 9DW, they did not include major portal vein thrombosis. Now, if we are talking about comparator, the only comparator with lenvatinib was the Checkmate 9DW compared to sorafenib and Himalaya and IMbrave 150. Let's look what matters. Here, the follow-up only is 15.6 in the IMbrave, Himalaya 33 months, 35 months in the Checkmate 9DW. PFS was the highest in the Checkmate 9DW. Yes, also lenvatinib did very well, so it's similar to what we are seeing with nivo-ipi. But median overall survival is the highest here in the Checkmate 9DW, 23 months. Comes next is IMbrave 150, then Himalaya. Objective response rate, we are talking about 36%, then 9DW, less in the IMbrave 150. Duration of response for those who responded is 30 months versus 18 months in the IMbrave. Now, if you look at the grade 3 for toxicity, the more gentle one is the stride regimen, but yes, you will get less efficacy here. But if you look at the Checkmate 9DW, we're talking about 42% and 42% or 43% in the IMbrave 150, similar toxicity but different taste. So you will deal with different setup of side effects. So single agent, is there a room for it? Dr. Ashwag, she's a big believer in the single agent IO, and I do so. Now, especially it is easier for the patient compared to giving lenvatinib or sorafenib with all these side effects. So durvalumab in the Himalaya was tested out and showed median overall survival of 16 months. So this is great compared to sorafenib of 13 months. Yes, it is non-inferiority, so it's not proven to be superior, but it is there as a good option. Now, nivolumab, it is still in the guidelines, at least in ASCO guidelines. It is negative trial, but it was not a superiority trial. So you still can use it as an option in later lines. Tislelizumab, but this was tested out in the Chinese population, and it did work out as 15.9 versus 14.1. Issues with single agent IO, it's easy. Patients will have not much side effect. We'll give it every 4 weeks, fine. But you don't anticipate a lot of objective response rates. So if you're looking for response rate, your lenvatinib maybe, or giving lenvatinib is a better option. Special population. How many of you gave a child B IO or give like lenvatinib? A line, okay. But if you look at the child B score in the TKIs, it's not the best, honestly. Either even sorafenib, when they looked at the databases and retrospectively, is not the best. Either sorafenib, regorafenib, or even lenvatinib. But if you look at nivo as a monotherapy in the child B, cohort 5 in the Checkmate 040, yes, you are getting less side effects. As I mentioned earlier, it's always the selection of the patient. Good liver function, that's a good outcome. But still, we did not see more grade 3 for toxicity in those with a child B score compared to child A. but less efficacy. About etiology. Anyone changing its treatment because of etiology? ولا ما تفرق؟ كده سربي سريع. No? ما تفرق. هنا. ولا أنت ومالكم في المدينة. أنا أوقف أنا هنا. Right. So it doesn't matter regardless of the etiology, whatever you're gonna use. Yes, TKIs kind of help. Now, if you look at IO agent in the Himalaya, did help in viral etiology. Now, you will see it in the Checkmate 90W based on the etiology. It doesn't matter. With that, I conclude. Thank you so much for listening.
Thank you, Dr. Ali. Very elegant presentation. No, stay on the body. Yeah, you will receive the questions over there. Yeah, very elegant presentation as always. It's always difficult when you have like different treatment options. And we don't have head-to-head comparison. So we are trying to drive the differences and looking into the details where the devil usually exists there. So any question for Dr. Ali?
Questions?
So let me ask you, Ali, because Ashwag has concluded in her talk that she will reserve Nivo Ipi where patient might need the best response. Okay. So would you agree with Dr. Ashwag with this conclusion, or would you say that Nivo Ipi is more appropriate in these categories of patients of HCC?
Okay, so as of now, I think is the default should be either Nivo Ipi or atezolizumab response. There was no major difference in talking about 36 or 30%. So Nivo Ipi, I will preserve it for those, I would say at least till I build my practice, which is good performance status. Has to be every other. You will ask me why. At least in my opinion, they have access to care, because if I have side effects on my patient in vision, for example, and they will have, I need them to be accessing, healthcare at least, looking at their labs frequently, and know that my patient I can see every 2 weeks with no burden. But if you look at the numbers, to be honest, Nivo Ipi is outperforming all three options. Now, in terms of response, honestly, I don't think it is mattering that much. I think regardless of the burden of the disease, at least in my opinion, I would go with Nivo Ipi. Doesn't matter if there is more disease burden compared to less disease burden. Now, there are other factors. I think the age of the patient, liver function test. If I see the liver function test, LB2 or so, I might lean towards stride regimen because it's less hereditary for toxicity and patient might tolerate it much better. But otherwise, I think Nivo Ipi and atezolizumab are a great option for the front line.
Excellent. Any other question? Yeah, Dr. Ali?
That's it.
Yes, so just a quick question. If we have a patient who received Ipi-Nivo, excellent response, and initially he was not candidate for local region treatment, will you offer local regional or any additional treatment?
You will be surprised. So my patients, if I start with atezolizumab or Nivo Ipi or stride, and then I have a good disease control for a while, okay? And if my aim to think about maybe transplanting, if they have disease burden only in the liver, because we have a lot of long-term responders, then I might consider local regional therapy to start the biology and even consider transplant in this situation. Now, oligoprogression, as Dr. Ashwag was mentioning in her talk, is for those with oligoprogression. I don't shift lines. I usually go with local regional therapy. As I mentioned earlier in the talk, second line and beyond in HCC is very bad, and I don't see them responding that well. They usually progress through lines quickly.
Excellent. Any other question? Okay, with that, I would like to thank Dr. Ali for the kind presentation, and we would conclude the satellite symposium.
So thank you very much. Now we're going to have a break for prayer and lunch. It will be in the ground floor, and we'll see you again at 1:20. Thank you.
Assalamu alaikum wa rahmatullah. We will be starting in a few minutes. Also, I'd like to take the chance to remind you that we have shared the link in the chat box where you can join our next meetings, the one next week and the other one about breast cancer in February. So the links are in the chat. Feel free to register as well. And if you are interested to come physically to attend, please let us know. For the third attendee link collection, we will be sharing it at 2 p.m. to 10 p.m. So please stay tuned. We'll see you then, inshallah. Thank you very much. We will be starting in a few minutes.
Is it on and mic? Bismillahirrahmanirrahim. Welcome back. So we're gonna resume our activity. Now it's gonna be the satellite symposium by MSD. It's my pleasure to invite Dr. Abdullah Sham, who's a senior consultant medical oncologist at King Fahd Medical City. And he's going to talk to us about the immunotherapy approach in the management of MSI high metastatic colorectal cancer.
بسم الله السلام عليكم جميعا. Okay, السلام عليكم جميعا. Start with I would like to thank MSD. Special thank for our colleague Dr. Mohammed Al-Garni, Dr. Ashwaq for the nice invitations. I was asked to speak about metastatic colorectal cancers. And as everybody knows that was huge change in treatment paradigm of metastatic colorectal cancer in the last 20 years. Okay. Oh, the pointer is here. So I think this very common slide that approximately 15% of the patients with early colorectal cancer they have microsatellite instability. And when we go to the metastatic disease, approaching almost 4%, in Saudi Arabia, it's lower even than 4%. When we look for the prognostic impact of MMR status in metastatic colorectal cancer, we know it's a poor prognosis and based on FIRE3 and CLGB trials. And if you look for the overall survival compared to the MS stable disease, you can see this significant drop from 25 to 19 months and 29 to 21 months. The story actually started from the Lee et al. Trial, where they examined the PD-L1 blocker and with mismatch repair deficiency. And actually, this trial was strongly indicating those who has an MSI, you can see very significant objective response reaching up to 40%. And actually, the story starts from this clinical trial, where actually we have very nice, excellent, nice separation in terms of the progression-free survival, as well as the overall survival for those harboring MSI high patients. So subsequently, we have three important clinical trials. The first important clinical trial, where actually we have the final overall survival, the Keynote 177 trial, changing practice. So patient with MSI in the first line setting, treatment naive, excellent performance status with randomized to pembrolizumab versus the standard of care, which was actually chemotherapy plus or minus one of the anti-GFR or vascular endothelial growth factor. And the double primary endpoint was progression-free survival as well as overall survival. If you look for the baseline characteristic, it was equally balanced between the two arms in terms of the age, gender, performance status, liver metastasis, demographic, and right side, as you can see, majority, almost 70%, they were in right side. They did include all the patients with the BRAF and the KRAS mutant. And a matter of fact, we have a very excellent, nice separation in terms of the progression-free survival with a very significant hazard ratio of 0.59. You can see at 36-month, the rate was almost tripled or more than 4 times, 11 to 42, and you can see the reduction is almost 41% risk of reductions, and the median actually was doubled from 18 to 16 months. This is totally unheard of previously in patients with MSI cancers. So when we look for the progression-free survival, second, the time from the randomization to the progression on the next line treatment, again, the same benefit was continuing with a huge improvement in terms of progression-free survival from 29 to 54 months. This is something unbelievable, and it was never before in patients with metastatic colorectal cancer who are harboring the MSI. When we look for the overall response rate, as you can see, it's increasing from 33 to 45. And the most important thing that we have almost 13% complete radiological response. And if you look for at 24-month response durations, we are speaking about 83% compared to 33% with the chemotherapy. However, in spite of this huge improvement in progression-free survival, this was not translated to overall survival. However, there was a clear trend, and basically there was almost 70% crossover, which eliminate any possibility of overall survival. However, if you look for the median overall survival from 37 to 77, which is almost doubled, with a very significant hazard ratio. And very important when we have a new medications or new regimen to look for the adverse events. And if you look for the side effects, grade 3 to 5, actually was better than the chemotherapy. As you can see, it was almost 70% with the chemotherapy, dropped to almost 20% with the pembrolizumab. So when we look for, again, the new medication, which is excellent benefit and excellent survival benefit, progression-free survival benefit, with an excellent safety profile, we would like to see the quality of life, which was actually maintained, and it was not associated with any detrimental effect in terms of the quality of life. And the conclusion at 5 years, there was a clear trend for improvement in overall survival, was clearly eliminated because of huge crossover, almost 70%. And as you can see, the median overall survival from 44 to 54, adding almost 10% with a hazard ratio of 0.73. Very significant 3 and 5 years progression-free survival, and actually very durable response with the first line setting. And actually, this clinical benefit of the first pembrolizumab was very clearly established in the first line setting. So the second important trial, which is actually the Checkmate 8 HW, again, the same concept, first line, they were randomized to dual immunotherapy versus immunotherapy alone, which is the nivolumab, versus systemic chemotherapy. And they were looking for the progression-free survival in both actually nivo-EB versus chemotherapy, or nivo-EB plus versus ipilimumab versus nivolumab. If you look for the baseline characteristic in the first line setting, in all randomized was totally equally between the arms, and was balanced, very well balanced. And when we look for the progression-free survival, you can see there is a nice separation at 24 months from 14 to 72% improvement in progression-free survival. And very important, when we look for the nivolumab or dual immunotherapy versus the nivolumab, although it was looking at the hazard ratio 0.69, however, the boundary to be positive was not reached. So nivo plus AB versus nivolumab, you can see it was not met because basically they make the boundary of less than 0.0383, where actually in the trial it was actually 0.04. So although it looked very nice separations, however, it was not reaching to the statistically significant when they compare nivo AB versus AB versus nivolumab as a monotherapy. And when we look for the overall response rate, as you can see, 61 to 73, it was not something very huge. And complete pathological response from 31 to 35. And very important to keep in your mind, this again was not translated to overall survival. Again, the same concept of the crossover, high crossovers. And when we have, again, the same medication or new medication, we'd like to see the side effect. And as you can see, the serious side effect reaching almost 16%, doubled from the nivolumab as a monotherapy, was making huge concern for our patients. Now, this is a very important table that comparing between the nivolumab as a monotherapy plus nivo-ipilimumab. And as you can see, the median progression-free survival, although it was not reached versus 43, this was not met based on the specified threshold for statistical significance. So nivo AB demonstrated clinically meaningful progression-free survival improvement, only clinical. It was not statistically significant versus nivo as a monotherapy in centrally confirmed high MSI with 31 reductions in the risk of the progression of death. There was no new safety signal, and although overall survival data was promising, however, it still does not show clear overall survival benefit. So we have a two important now regimen, pembrolizumab as a monotherapy, and we have nivo-ipi as dual immunotherapy. The third important trial was the COMET study, which actually was in the last ASCO GI. They were looking for the concept of adding immunotherapy to chemotherapy versus monotherapy of atezolizumab. So basically, it was three-arm, the FOLFOX plus bevacizumab plus atezo versus atezolizumab. Now, the initial trial of the Keynote 177, they actually closed the third arm of the chemotherapy alone. So chemotherapy plus atezo and versus atezolizumab, and they are stratified according to the BRAF and metastatic site and prior adjuvant for colorectal cancers. So initially, this trial was amended to be as second line post immunotherapy in the first line. However, they changed their thought and they make it in the first line setting. And as you can see, there was only 40 patients in chemotherapy plus atezo versus 40 in atezo arms. Now, if you look for the baseline characteristic, regardless of the age, regardless of the BRAF, regardless of the tumor size, the baseline was unequally balanced. And when we look for the progression-free survival, actually, you can see very nice separations, 5 point versus 24. Atezolizumab was underperformed to the other immunotherapy. Remember, in patients with pembrolizumab was reaching almost 16 months. So 5.3 to 24 is because of the weaknesses of this arm, atezolizumab. We need to keep in our mind there is a huge difference between atezolizumab, nivolumab, pembrolizumab, and you can see there's a very nice separation when we add chemotherapy to this regimens. And again, when we look for this trial, very clearly, regardless of the age, the BRAF situations, prior adjuvant therapy, and the CA level and size of the tumor, all of them was in favor of combination therapy. So the progression-free survival at 24 months from 31 to 53, the overall response rate from 46 to 86, and complete pathological response of almost 36%. And as you can see, doubling the disease control rate. So, however, there was no overall survival difference at 2 years, and I'm not expecting to have any overall survival. They did not mention about the rate of the crossover. And we need to keep in our mind that the side effect was very genuine, as you can see. For the grade 3 to 5, we jumped from 43 to 89. So we have an excellent regimen showing progression-free survival. However, and expense of a very ugly side effect, which is almost like 82 of grade 3 to 5, was very huge. So again, this is the adverse effect, adverse effect, again, was higher definitely with the arm of chemotherapy. And based on that, the conclusion of this trial, keep in your mind, this trial was only for 40 patients and was amended to start with in subsequent line of therapy. They changed it to the first line therapy, where in spite of this, it showed clear progression-free survival benefits. However, there was a major concern about the side effect, which was approaching almost 80%. So the big question actually, we need to know why not all the patients, they respond very well to immunotherapy. This very important paper in the Natures where actually they define the potentially positive biomarker, and they put the high TMP, high neoantigen load, high expression of CD74. This is a potential, and the most important apology, those actually, they're hypersensitive for immunotherapy. And very important to keep in your mind, the visceral adipose tissue, those who are obese persons, they response, this is a potential negative biomarker, and those who has an antibiotic exposure, again, carry the risk of negative biomarker for the patient to receive immunotherapy. And again, if you look for those, for example, of low TMP, and those who has a liver metastasis, and those who has FOXP3, which is actually, there's a lot of ongoing on FOXP3, all of this actually ABC mutation, all of this actually, it's a negative biomarker. So the big question that we ask ourselves, shall we compare between the trial? The best answer is no, because if you look for the control arm and the checkmate, actually pembrolizumab was versus chemotherapy. And if you look for the nivolumab data, was versus double immunotherapy plus nivo plus EB. And clearly showed progression-free survival with the pembrolizumab. And when we look for the nivo plus pembro, equal efficacy in terms of the progression-free survival and overall survival. And clearly, when they look for atezolizumab, which is a chemotherapy plus atezo versus atezolizumab, is clearly atezolizumab was underperformed. So we need to keep in our minds, very difficult to have, selected between all of these clinical trials. So remember, we are still waiting for the data of nivolumab versus chemotherapy, which is going to give us a very excellent hint about the functions of immunotherapy in these situations. So we have single agent pembrolizumab as a first line option, double immunotherapy, another option, and we have the chemotherapy plus atezolizumab still not approved yet, because basically it's, as I said, although there was a huge progression-free survival benefit, the trial has main concern about, it was initially second line, then they moved it to the first line, 40 patients only, and the most important thing is the concern about the side effect, which is reaching almost 82%. So if I have patient in my clinic by tomorrow with this, very limited disease and patient asymptomatic, I may go with the pembrolizumab as a monotherapy. If I have very extensive disease, I may go with double immunotherapy. However, we could use nivo-EB in this, and we could utilize pembrolizumab in the other patients. So we didn't know anything about MSI at the meantime. We have the polo-gene. However, there is a lot of things. What we are seeing only the tip of the iceberg. There is a lot of things coming in the pipeline. FOX3 is coming. We have also microglobulin is coming. There is a lot of things coming that we need to know who's, for those who has an MSI, who are actually patients that they may benefit, who is the patient that can receive chemo plus immunotherapy instead of immunotherapy alone. So in my conclusion, MSI should be routinely tested, and for any patient with metastatic colorectal cancer, immune checkpoints are highly effective in MSI. However, keep in your mind, not for every patient. Nivolumab, ipilimumab, or single-agent pembrolizumab is valid option in the first-line metastatic colorectal cancer harboring MSI high. And atezolizumab as a monotherapy is not an option. Trial design issue and clearly patient selections. And commit was amended post keynote 177 and ended up by a very small number of patients. So the details matter. We're still waiting for their publications. Finally, the future is coming very soon for the local therapy, especially the SBRT plus immunotherapy, combination therapy, especially with the TKI in subsequent line of therapy. And definitely we are going to look for definitely other biomarker. And with this, I would like to conclude. Thank you so much.
Thank you very much. Thank you, Dr. Abdullah, for this excellent presentation. We may have a few minutes for questions. Any question? So, Dr. Abdullah, I have one question. So, it's for the choice or selection of immunotherapy. You already mentioned about what factors you might consider, but what about other predictive factors, like someone with BRAF mutation and MSI high? Will it impact your choice of dual versus single agent immunotherapy?
So for the BRAF, we need to remember that the checkmate and the keynote, they did include the BRAF patients, while the breakwater did not include the MSI, they excluded. So the MSI is going to take over, any other mutation. So if you have any patient with MSI, regardless of the KRAS, NRAS, and BRAF, it should be the standard of care. Keep in your mind, the keynote actually, those who has mutant RAS, there was no significant benefit. However, this is a subgroup analysis, and we need to keep in our minds, not going to predict either to start yes or no based on the RAS status. So if I have a patient with MSI, both of them is valid options. If I have a patient who's 70 years old, minimally symptomatic, multiple liver, small liver disease here and there, lung, I usually go with the pembrolizumab, and I have an excellent result. We have some patients that we have complete pathological response, complete radiological response on pembrolizumab. يعطيكم العافية. شكرا.
So now we'll move to the second satellite symposia. It's about Stanislaus satellite symposia. It will be presented by my dear colleague, Dr. Kanaan Shamari, who's a consultant medical oncologist at King Abdulaziz Medical City. And he's going to talk to us about navigating biomarker overlap in advanced gastric and gastroesophageal cancer.
Thank you, Dr. Mohammed, and I also would like to take this opportunity and thank Dr. Mohammed Bakhadlek for his kind invitation and support for this presentation. So I was given the task to talk about overlapping biomarkers and sort of newer evidence in gastric cancer. So very briefly, gastric cancer prevalence, it is the 5th most prevalent cancer worldwide. In Europe, it is the 6th most prevalent. Again, in Europe, 1/3, or actually more than 1/3 of these patients do present with metastatic disease, indicating that the majority of patients actually present late. And the 5-year overall survival has been poor until the addition of immunotherapy and targeted therapies in gastric cancer. What about the prevalence of biomarkers? So if we talk about the known biomarkers, HER2 positivity is about 1 in 5 patients, so approximately 20%. CPS more than 1 is the majority, around 70%. CPS more than 10 is between 20 to 50%. And microsatellite instability in gastric cancer is still quite low, ranging between 3 to 7%. Now, if we're talking about newer biomarkers such as FGFR2b, it's about prevalent in about 30%. And Claudin 18.2 positivity is prevalent in 38%. So survival did improve significantly over the last few years. And as you see here, this indicates the overall survival in months per clinical trial. So if you see with the addition of immunotherapy, here you see nivolumab and pembrolizumab, you do see that the overall survival exceeded a year compared to the historical less than 1 year chemotherapy. And if you see the addition of Herceptin and pembrolizumab as in 811, it reached a near 20.1 months. And probably the new player now, zanidatamab and tislelizumab, exceeding 26 months significantly. So what are the first line options that we have? This comes from the 2024 ESMO Living Guidelines, and it does give us an idea of what to do with biomarkers. So if you are HER2 positive and you're PD-L1 positive, then Keynote 811, adding Herceptin plus pembrolizumab plus chemotherapy. If we are talking about PD-L1 CPS score of more than 1, then nivolumab is approved, or more than 5, nivolumab is approved. If we're talking about CPS score of more than 1, then pembrolizumab plus chemotherapy are approved. With Claudin 18.2 positivity, then zolbetuximab as per GLOW and SPOTLIGHT trials. And if you're deficient in MMR or microsatellite unstable, then immunotherapy should definitively be given, whether it's given with chemotherapy or not. I think this is up for discussion. And I think this is going to be the new player, zanidatamab plus an immune checkpoint inhibitor as in Horizon, which was presented recently in ASCO GI by Elena Elamova. Very impressive results. So if you're HER2 positive, then 811 was a practice-changing study where pembrolizumab was added to Herceptin plus chemotherapy with dual primary endpoints of overall survival and progression-free survival. Both of these were positive. Here's the PFS compared to placebo. If your PD-L1 CPS score is more than 1, then PFS is 10.9 months compared to 7.3 months with a hazard ratio that is significant. Now, this did get accelerated approval. I remember this a few years ago when the objective response rate data came back as almost 75%. PD-L1, so we have 2 practice-changing studies, Checkmate 649, started with nivolumab added to chemotherapy compared to chemotherapy alone, and the primary endpoints were overall survival and progression-free survival. And there was an overall survival benefit in all comers, and this was enriched in PD-L1 CPS score of more than 5, reaching 14.4 months, compared to chemotherapy, which reached 11.1 months. 859, Keynote 859 was also a practice-changing study with pembrolizumab added to chemotherapy compared to chemotherapy alone. Primary endpoint was overall survival, with secondary endpoints being PFS, objective response rate. And again, this was practice-changing with an overall survival benefit that was enriched in both CPS score more than 1 and CPS score of more than 10, with the more than 10 reaching 15.7 months. Now, it's important to show some of this data, which is the US FDA Oncologic Drugs Advisory Committee meeting, where they meet regularly to assess evidence and come up with their own conclusions. So this came from their meeting that was held in late September of 2024. And what I want to show here is that if your CPS is positive, then your hazard ratio is going to be favorable for the addition of nivolumab in Checkmate 649. If your CPS score is negative, then benefit may not be as good. And as you see here in the hazard ratios, the hazard ratio confidence interval did cross 1. Again, same thing for 859 in the intention to treat group, the hazard ratio is 0.77, indicating benefit. And if your CPS score is more than 1 or more than 10, hazard ratios were also quite positive. However, in the negative group, and I know this may be actually difficult to interpret, but you see the hazard ratios being in the 0.8, 9 range, and 2 of them actually crossed 1, indicating perhaps non-benefit. And if you're definitely PD-L1 CPS score negative, less than 1, then there is no benefit actually of adding immunotherapy. And this was shown in Checkmate 649, Keynote 859, as well as Rationale 305. Right, let's talk about Claudin 18.2. So Claudin 18.2, this is a tight junction protein that is expressed in normal gastric epithelium, and it's also expressed in patients with gastric or GE junction adenocarcinoma. It is associated with younger age, more prevalent in females, as well as high prevalence in white and Asian patients, and patients with diffuse type disease. And Spotlight study was a practice-changing study. It was published a couple of years ago by Kohei Shitara and the Japanese group. And basically what they've done is they have given zolbetuximab to FOLFOX for 4 cycles, followed by drop of oxaliplatin and continuation of zolbetuximab, compared with FOLFOX, followed by 5-FU maintenance. And the primary endpoint was progression-free survival. Secondary endpoints were overall survival. If you look at the PFS, it was significant, reaching 11.0 months compared to 8.9 months, with a hazard ratio of 0.73. So definite benefit when we add zolbetuximab. With regards to overall survival, it actually reached 18.2 months compared to 15.6 months for chemotherapy alone. Hazard ratio was 0.78. Now, this was also statistically improved in the PPS population. PPS population excluded patients who did not receive the study treatment or lacked sufficient study drug exposure. Some of these patients, when they get significant toxicity or nausea, they drop the medication. They also benefited. Now, I did attend a presentation a few weeks ago in ASCO GI, and this was phase 2 trial presented by Kohei Shitara, which is the Illustro study. So they added nivolumab to zolbetuximab plus chemo compared to basically zolbetuximab, or it was actually a single arm study. But they added nivo with zolbetuximab. So let's look at the results. So with regards to objective response rate, if you're Claudin 18.2 high, meaning more than 75% Claudin 18.2 positivity, objective response rate was a significant 68.1%. And as you can see, the waterfall plot was quite impressive. Now, progression-free survival was 18 months in patients who are Claudin 18.2 high. So 18 months as progression-free survival. This is quite significant. And if your Claudin 18.2 high and PD-L1 CPS score was more than 1, then progression-free survival was an impressive 23.6 months. This is quite significant. And this is still early for overall survival benefit. Now, again, this was a single-arm phase 2 trial. And there is a phase 3 that I'm going to show that is upcoming. So does the addition of immunotherapy mean more toxicity? You see any grade nausea is 80%. However, Astellas have created a 4-drug regimen for anti-emesis that actually controls this quite effectively. You do also see grade 3 neutrophil count decreased here, and this is expected. Lucerna is the randomized global double-blinded phase 3 trial that is actually testing this exactly. Interestingly, Illustro added nivolumab, whereas Lucerna is actually adding pembrolizumab. So I'm not sure why, Mohammed, but anyway, we would like to see, how this pans out, and I think it probably will be practice-changing, provided, with the significant signal in the phase 2 clinical trial. Now, this is, I think, the part where we're going to have a bit of debate, and this is the interesting part, which is the co-expression. So multiple studies and different numbers. So 3 studies have actually described co-expression between Claudin 18.2 positivity and CPS score of more than 5, ranging between 17% to 47%. So definitely there is significant co-expression between these groups. Now, a real-world study from a Spanish and an Italian group, this was presented and published, presented in last ESMO, basically showed Claudin 18.2 positivity with PD-L1 CPS score of more than 1 being prevalent in 45.7%. If your CPS is more than 10 and you're Claudin 18 positive, you're going to be prevalent in 46%. So it's quite, there is significant overlap in such patients. And this was done, in 560 patients. So significant numbers. Thank you. So moving on, and I'm almost reaching the end. Yes. So how do you integrate biomarker co-expression? So this is quite interesting, although numbers are quite small, but what this is showing that if you're Claudin 18 positive and you actually receive immunotherapy alone, that the objective response rate and perhaps progression-free survival are going to be shorter in such group when they're not exposed to zolbetuximab. So very interesting data and something to strongly consider. Now, this comes from the Spanish pathological group and the Japanese groups, and they show a potential treatment strategy with the addition of basically Claudin 18 positivity. So I want to focus on the Spanish group here. Now, with many biomarkers, it's difficult to actually know what to do. So if you're deficient in MMR, then it's definitely going to be immunotherapy plus minus chemotherapy. These are prevalent in about 3 to 7% of patients. If you're HER2 positive, then 811 is definitely the way to go, provided your PD-L1 CPS score is more than 1. If you're Claudin 18 positive, then it's definitely going to be zolbetuximab in addition to chemo. However, if your CPS score is high, then maybe the addition of nivolumab is the way to go. As I've shown you, progression-free survival almost reaching 2 years. If your CPS score is more than 10, I think is quite an impressive signal. Now, if you're Claudin 18 negative and your PD-L1 CPS score is positive, then I would personally follow US FDA approval. If your CPS is more than 5, then probably nivolumab. If more than 1, then pembrolizumab has strong evidence. Thank you very much. So any questions? No questions?
So now we'll move to our last session. It's going to cover lower GI cancers. It's my pleasure to invite my dear colleagues, Dr. Abdelhamid Faqih, who is a consultant medical oncologist at King Fahd Medical City, and Dr. Walid Al-Silri, consultant medical oncologist at King Fahd Specialist Hospital in Denmark. Please, Dr. Walid and Dr. Abdelhamid.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, thank you for scientific committee, organizing committee, Kanaan, Muhammad, Ashwaq for continuing this annual activity. And it's my great pleasure today to handle this session with Dr. Abdelhamid Faqih. First, a talk with dear friend Dr. Kanaan Al-Shammari. He will talk about the clinical application of the ctDNA in the early and metastatic colon cancer. And this is one of the hot topics every meetings to talk about the ctDNA and how is that applications in to utilize in our practice. Dr. Kanaan.
Thank you very much, Dr. Waleed, for the kind introduction. So I was given the task to talk about clinical applications of ctDNA in colorectal cancer. So I'm going to focus on new and exciting data, which is going to focus on MRD testing, the new concept or the new data on very early plasma ctDNA. And I'm going to briefly touch upon ctDNA-guided adjuvant therapy, then I'll talk about newer approaches. So what is circulating tumor DNA? Basically, it is a dynamic marker of tumor burden. When your cancer cells die, they release DNA into the bloodstream. This is captured by multiple different assays. The half-life of this is actually quite short. It's minutes to a couple of hours. So you need continuous death of cancer cells for you to have a continually positive ctDNA in the plasma. Many studies are investigating ctDNA, including breast cancer, colon cancer. These are probably the oldest, and more recently, and lung cancer as well, and more recently pancreatic cancer. And it does allow prospectively to assess tumor burden and perhaps response to chemo or immunotherapy. Now, the last 3 years have had significant studies published and advancements into ctDNA and advancements into assays that actually detect ctDNA. So I'm going to touch upon these in the upcoming few slides. So MRD testing is quite, I'm not going to say new, it's probably been in the market now for 4 or 5 years. However, its uptake everywhere in the world hasn't been as high. However, I do think that it has benefit. So let's take this scenario here where your patient gets surgical resection. You do MRD testing approximately 6 weeks post-op, so 4 to 8 weeks. And if you do detect circulating tumor DNA, there is a critical window of opportunity here where you have low titers of ctDNA, maybe less resistant clones of genes where you can attack them with chemotherapy, and hopefully you get a better disease control and better patient outcomes with a less chance of recurrence. However, if you wait, tumor starts to develop, you get a measurable tumor on imaging, you have more resistant genes and more clones, then it's going to be quite late to actually attack this with systemic therapy. And we know that there is inferior disease control when this happens. Now, this investigator, this was led by the Melbourne group, led by a scientist and an investigator named Jenny T. She actually investigated 2 different panels. She did whole exome and whole genome sequencing, where she identified approximately 90 something genes that were specific in colorectal cancer. And then they did the targeted panel, which tests basically 15 genes. So they compared the sensitivity and specificity for both of these tests. With the targeted small gene panel, the median mutant positive patients was actually 3 in the targeted panel and 29 in the whole exome or whole genome sequencing. Specificity increased to 100% in the wider panel, and sensitivity also increased to 85.5% compared to 57% in the smaller group. And if your ctDNA is going to be positive, then the likelihood of recurrence is going to be extremely high, as shown here. Like, what about different MRD tests? So there is an off-the-shelf test that you do at different time points. It is quick, it's probably cheaper, but the ability to actually detect circulating tumor DNA is moderate. It's not very sensitive. However, your tumor-informed, which is the latest or the newest technology, requires the patient to submit a tumor tissue. This goes to the lab, it gets sequenced, and they look for mutant genes. And they design the MRD test or the liquid biopsy based on these mutant genes. Sensitivity increases significantly. It is slower, it is more expensive. However, it's definitely more sensitive and will provide you with much more information. And this is what they mean by personalized MRD testing. Now, I want to share a very interesting study. Now, this was done in the States by an investigator. They went back to biobanked blood that dates back to the 1990s. They took patients who were enrolled in a study called atherosclerosis risk in communities, where they had multiple patients who have had Q6 monthly plasma taken and biobanked since the 1990s. They followed these patients to see if they develop atherosclerosis. This investigator was able to actually design a study and went back to these biobanked samples. So she took 52 patients, probably got a fund for this, and divided them up into 26 patients who developed cancer later and compared them to controls who never developed cancers. They followed them up for about 20 years. And what's interesting here is they designed an assay where they took early plasma, so 6 months prior to developing of cancer, and they did sequencing for it. They removed germline mutations, they removed CHIP, clonal hematopoiesis, so a very sensitive assay. And they took this and they went back to 3 years before developing cancer, and they tested these patients 3 years, they tested their plasma 3 years before the development of cancer. And they called this very early plasma. And what I want to show here is that half of the patients actually had detectable ctDNA 3 years before the development of cancer. And this was found by this investigator. So new technology, extremely interesting. You can actually capture cancer well before it actually develops. And the mutant allele frequency here is extremely low due to the highly sensitive assay that this group have developed. And definitely, developing technologies to achieve very early detection does require 50-fold higher sensitivity than detecting cancer months prior to diagnosis. But imagine discovering a cancer 3 years before it actually develops. And how you deal with this information is definitely controversial, but definitely this is a window of opportunity. A quick case. You are approached by a 55-year-old woman who comes to your clinic who has high-risk stage 3 cancer, and she asks you about MRD testing. I'm not sure how many of us have had MRD testing questions in their clinic. Can I get a show of hands? Have you had any of the patients asking you about MRD testing? I have. مسألك وبدر. Right. So MRD testing, I think, is important. Many studies have actually developed. Probably the earliest group was the Japanese group in Galaxy, where they took MRD negative patients and compared them to MRD positive patients. If you're positive, the likelihood that you're going to develop cancer is extremely high. And some of these patients benefited from adjuvant chemotherapy. What do the NCCN guidelines say about MRD testing and circulating tumor DNA? It does say that, and this is in the October 2025 guideline, it does say that ctDNA is a prognostic marker. However, there is currently insufficient evidence to recommend routine use of ctDNA outside of a clinical trial. And de-escalation or escalation of treatment are not recommended based on ctDNA results. So they are talking about the ctDNA in the adjuvant setting, and participation in clinical trials is encouraged. If you're MRD positive in the sensitive plasma, not the very early plasma, this study actually shows that 50% of the time you're going to get measurable disease on scans. Is it very sensitive? Probably is, but are we actually detecting them early? Maybe not. On dynamic 3 studies, this was also the Melbourne group presented by Jenny T, where she presented in the ASCO annual meeting one arm of the study, which is the escalation arm. So there are 2 groups, ctDNA informed group and standard management. If you're ctDNA positive, you should escalate, and she gave choices to physicians. So if you already decided no chemotherapy, then you should escalate to 5-fluorouracil capecitabine. If you decided on single agent 5-FU, then you should give 6 months of oxaliplatin. If you decided 3 months, then you should give 6 months. If you decided 6 months, then you should give folfoxirine. And the results basically showed that no indication that escalation does improve outcomes for such patients. And the p-value was not significant. Perhaps they recurred less, the ctDNA informed escalation, but this association was not statistically significant. In the de-escalation group, the caveats here is 10% of them were MMR deficient, and 1/3 of these patients were high risk. Again, no significant benefit with de-escalation in dynamic 3. If you are high risk, then the difference between ctDNA guided group is actually higher compared to the standard group. If you're lower risk, then the difference is actually smaller. Now, there is a large study in North America, which is Circulate North America, and it is currently recruiting, and it does basically use ctDNA to guide adjuvant therapy, using ctDNA monitoring and giving escalation or de-escalation of chemotherapy. So my key takeaway messages from this talk is that I think we should follow guidelines when evidence is not clear, as in here with ctDNA-guided adjuvant therapy. It is definitely an exciting and developing field with ultrasensitive MRD testing and ctDNA data from very early plasma that actually showed that you can detect or predict the development of cancer 3 years prior to its happening. I think there is no consensus yet on treatment after tests coming back positive. And if the test comes back to me positive with ctDNA after surgery, and it comes to Dr. Abdullah, I think every one of us will have a different way of treating. Circulate North America is awaited, and I think future prospective clinical trials that utilize newer technologies and testing methods are required to definitively demonstrate clinical utility. And I thank you for listening.
Thank you, Kanan. It's really is excellent talk as usual, and very interesting topic, by the way. I think this is the way how is then change the practice for the ctDNA. Moving for the second talk, Dr. Fahd bin Shamsa, he will give the talk about the adjuvant versus the neoadjuvant IO in non-metastatic colorectal cancer. Dr. Fahd, please.
Thank you, Dr. Walid, Dr. Hamid. Thank you for the Dr. Shwab, Dr. Kanaan, and Muhammad for the invitation and their great team for really help and nice hospitalization and organizing. I'll be talking to you about immune therapy in early colon cancer. I will focus on adjuvant versus neoadjuvant. As you know, now we have two approaches to approach early colorectal cancer, and I will show you the data, then I will share with you my impression about these data. So we'll start talking about rectal cancer, and the case is a little bit easier than colon cancer. We know the standard treatment is surgery, radiotherapy, and chemotherapy, and 1 in 5 patients, or 1 in 4 patients, they achieve complete response with this trimodality approach. But about 5 to 10% are MSI high, and we know they are not very responsive to chemotherapy. And we know from the earlier presented by Dr. Abdullah Sharm that colorectal cancer, MSI high, they are sensitive to immunotherapy in advanced stage. So that led to the design of this, maybe the most beautiful trial I have seen in oncology. I remember we were there when it was presented in the ASCO. We were all so proud of this study. It's a single-arm phase 2 study, 16 patients, 9 cycles of immunotherapy, dostarlimab. Very smart design. So they receive the immunotherapy. If they have complete response, they continue on observation and follow-up non-operative approach. If they have residual disease, then they will go to the conventional chemoradiotherapy, and then they will be evaluated again. The evaluation is radiological and also by endoscopic evaluation. All patients, they achieved complete response. We were all happy with this study. 0 grade 3 for adverse events, more than 10%. So since then, none of the patients required surgery, chemotherapy, or radiotherapy, and no recurrence observed in all of these patients during the follow-up according to the trial design. So since then, immune therapy, neoadjuvant immune therapy, dostarlimab is the standard of care for rectal cancer. We switch gear to colon cancer. The case is a little bit different, and the rationale is the same. 15% in colon cancer, they're deficient MMR, and they're sensitive to immune therapy. We know they are resistant a little bit to chemotherapy. So they designed this, again, very smart study, niche 1, 2, and 3. The niche 1 is nivolumab, only 2 doses of nivolumab and 1 dose of ipilimumab, included 16 patients, and all of patients had major pathological response. 60% had complete pathological response. That was escalated to niche 2, a study in 2022, now including 112 patients. Most of them are high risk stage 3. More than 70% they were T4 disease. Really nice study published in New England Journal of Medicine. Again, 2 doses of immune therapy nivolumab and 1 dose of ipilimumab, 2 weeks apart. Surgery was scheduled in 6 weeks. Grade 3, 4 adverse event were 4% only. And most patients had major pathological response, more than 90%. Complete response was 68%. And you don't need numbers to see this very nice waterfall response rate graph. And then niche 3, they used another anti-lag 3 relatlimab with nivolumab. Again, it's a very similar design, and the complete response rate was 79%. Also, there was a real-world data published recently by ESMO looking at patients who received neoadjuvant pembrolizumab or nivolumab ipilimumab. It was found if patients received dual immune therapy, they achieved 67% complete response, and in pembrolizumab it was 33%. So patients with locally advanced dMMR, colon cancer, neoadjuvant immune therapy ensure that early introduction of very effective treatment to a very sensitive disease, very short duration of treatment, only 4 weeks of treatment, and this will result in substantial pathological response. And that's why it's a preferred regimen in the NCCN guidelines. So these are phase 2 studies, and you expect, because it's not very common to take you time to collect a big sample number for MSI high and design trial, but they did it in the adjuvant setting where they explored adding atezolizumab to FOLFOX, so 6 months of treatment, and then they will continue another 6 months of atezolizumab to complete 1 year of immune therapy compared to FOLFOX chemotherapy. All of patients, of course, they are node positive, stage 3. So T4 disease was 32%. N2 disease, so all of them are node positive. N2 disease is 36%. This is the primary endpoint in this phase 3 randomized study, and adding atezolizumab to FOLFOX achieved absolute benefit of 10% in disease-free survival. Now 86.4% with hazard ratio of 0.5. Very significant study, practice changing. All the key subgroups derived the benefit of atezolizumab. Overall survival data was immature, but it's expected to be confounded by subsequent immune therapy because all of these patients, if they recur or become metastatic, they're MSI high, and they should receive immune therapy. So this may affect the overall survival data. But the study was positive, phase 3, randomized, practice changing. Of course, adding immunotherapy to FOLFOX and treating patients for 1 year would result in increase in adverse events. It was 83% compared to 70% for the control arm. Also, immune-related events were increased, but they were in single digit, and we know now we are very familiar with immune-related adverse events. They are manageable. So in conclusion, for the atomic study, adding atezolizumab to FOLFOX demonstrated statistically significant and clinically meaningful 50% risk reduction of recurrence or death compared to FOLFOX chemotherapy. And atezolizumab plus FOLFOX is a practice-changing and a new standard treatment for patients with dMMR stage 3 colon cancer. So in rectal cancer, it's clear case neoadjuvant treatment is a preferred standard of care choice for patients. When it comes to colon cancer, we don't have head-to-head between a neoadjuvant versus adjuvant. Neoadjuvant, short duration, effective treatment, high PCR, but they are small sample studies and phase 2 study. In the adjuvant setting, it's long duration of treatment, with a little bit increase in adverse event, but it's phase 3 randomized study. But I think adjuvant, the neoadjuvant treatment, of course, they achieve excellent outcomes. So there's no benefit of giving adjuvant if patients already received neoadjuvant immune therapy. I think adjuvant immune therapy, chemotherapy combination should be reserved for those patients who could not receive neoadjuvant immunotherapy. There is an important ongoing study, AZUR-2 trial. It's a phase 3 randomized study that's including preoperative dostarlimab, a newer strategy of treatment that we await to modify further our approach with early stage MSI high colon cancer. Thank you very much.
Assalamu alaikum. So because of the issue Dr. Fahad is leaving, so if we have any questions related to Dr. Fahad bin Shamsa topic, we can ask it now. Follow Dr. Walid.
Thank you, Dr. Fahad. Fahad, now with what you are presented that regarding the neoadjuvant and adjuvant, how to be look for that? How can be, I mean, affect that's how to be select the decision for our patients when he came for a rectal, that's clear, for the colon cancer, the neoadjuvant approach or the adjuvant therapy, atomic or the niche, 1 or 2.
Thank you, Dr. Walid. You know, it's now standard of care to test for MSI status, even in early stage. So if my patient is MSI high, I will go ahead with neoadjuvant immune therapy, but we still, the risk with, I mean, the doubt or uncertainty with neoadjuvant because you don't have a pathological staging. So you might over-treat because many of the times, before even the era of immunotherapy, we see radiologically they are node positive, but when they, we decide for surgery and we expect them to come for adjuvant chemotherapy, but then they turn to be stage 2 disease node negative. So that's the maybe the downside of neoadjuvant treatment. I think there is risk of over treatment. And for the adjuvant immunotherapy, you are certain that these patients need treatment. So there is no risk of over treatment. But we still sometimes receive patients referred to us after surgery. So if I receive a patient who already had the surgery, of course, I'm happy to have the atomic treatment strategy to apply for this patient with adjuvant immunotherapy chemotherapy.
have used combination Epi-Nivo in stage 4 liver limited disease, most likely, where we use four doses of Epi. While in localized disease in niche 2 and 3, they used single dose of ipilimumab. So, what's your thought about differences in the doses between the two? Can we utilize 1 dose or 4 doses of Epi? The main issue is because of toxicity. This is the reason.
Right. So, thank you for this important question, Dr. Ali. You know, the difference of treatment is surgery, and you don't want to delay surgery. We have learned from some clinical trials in immune therapy, sometimes the dose does not matter. I think the immune therapy, they work differently than chemotherapy. In several studies, it's only 2 doses of immune therapy. And they all really showed in this short-term duration, only they are randomized to surgery within 6 weeks, and you achieve substantial complete responses. I would recommend this shorter treatment, 1 dose of Epi, rather than subjecting patients to more treatment, because as you said, it will come with the risk of adverse event. So I think 2 doses so far is more than enough for these patients.
Thank you, Dr. Fahad, and thank you, Dr. Walid, also. We'll move now to the next speaker. So it's my pleasure to introduce Dr. Ali Zahrani. He's a senior oncology consultant in King Fahd Medical City. Dr. Ali will talk about the role of TNT in rectal cancer. Floor is yours, Dr. Ali.
بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Thank you, Dr. Hamid. Thank you, Brazil Committee, Dr. Ashwan, Dr. Muhammad, for the invitation. So, my topic today is about TNT, and I will concentrate about the two types of TNT, the induction and consolidation chemotherapy. You know, since 1980, the main aim of treatment of rectal cancer is trying to get rid of the primary at whatever cost. And this is what used to be called cancer disease focus. Now, you know, with the introduction of many trials, especially TNT, now it is some sort of patient-centered care. You know, the quality of life, the saving the patient's permanent stoma are really also matter a lot for the patients. You know, this is really very important. You know, I'm sure, you know, your patient had sometimes were telling you that they would rather die than having permanent stoma. And this is really sometimes a very important issue that we need really to consider for those patients. You know, if the patients are really not willing to have permanent stoma, then you know, there is another way of treating these patients. And this is very important to be documented at the beginning, since it might actually direct whatever is coming in the future. And it was found that almost 80% of the patients, when they have complete clinical response, would usually like to have a watchful waiting policy. You know, radiation therapy is not just one shot type of treatment. You know, if you give the radiation therapy and you end the radiation therapy, it still work for months and sometimes for years on the normal tissue. That's why, you know, some of the patients who have some fibrosis, some, you know, affection of the nerves, even years after the radiation. So it's really very important to recognize that radiation would usually work with time. And if you wait more and more, the effect of radiation will be really very apparent later on. Another fact is 25 and 5 is not enough dose compared to the usual dose of 50.4 or 54 gray. The 25 and 5 is corresponding between 30 and 40 gray. not the 50.4 and 54 gray. So this is really very important issue to consider when we look to the trials and when we decide the treatment of patients. Another important fact is that chemotherapy tolerance is different. We know that only 75% would tolerate adjuvant treatment, while more than 90% would be able to receive the full chemotherapy in induction. Less than that as a consolidation. So if our aim to give chemotherapy in full, then we might consider giving them as early as possible. So let us talk about the locally advanced cancer. And this is really very important graph. This is a sagittal MRI, and this is really mandatory for all patients. This imaginary line here is very important to be considered. It is a line between the sacral promontory and the upper part of the symphysis pubis. Here you will have all the rectum there. So above this, the rectum is mobile, not covered with the peritoneum, and it cannot be treated with radiation therapy. As you can see here, the white arrow is the peritoneal reflection, above which is the upper part of the rectum, and the upper part of the rectum is sometimes now treated as a colon cancer. So this is a very important arbitrary line that need to be considered during the tumor growth. Another thing about the lymphatic drainage, we know that the upper rectum does not drain to the lymph nodes in the pelvis. That's why, if you give radiation therapy, long course radiation therapy to the tumor at the upper part of the rectum, you might actually lose sometimes. So that's why if you have an upper rectal cancer, you need to introduce the induction chemotherapy as soon as possible, if it is possible. These are the key MRI reporting criteria. It needs to be there in the reporting system. Unfortunately, nobody is practicing this, but this is what is really recommended by the European Gastro-Abdominal Radiology Group. In the tumor level, the T stage, mesorectal facial involvement, extramural venous invasion, nodal status M2, and lateral lymph nodes. All these are very important, and it would definitely decide what is the future treatment for each patient. So according to the MRI criteria, we have 3 or 4 groups. We have the low risk, we have the intermediate risk, and we have the high risk, and accordingly, the treatment will be actually decided. These are the criteria of very low risk. The ASTRO and ISMO have their own criteria, and according to this, few trials have shown that only surgery is of benefit of these low criteria. So surgery alone with the total mesorectal or even local excision is enough if we have low criteria that was mentioned before, according to the MRI. This is the update of OCAM trial. They randomized, or they actually categorized their patient according to the MRI, and it was found if it is low risk, surgery alone is enough compared to the concurrent chemoradiation therapy or radiation therapy before surgery. So let us talk about now the TNT. The concept of TNT actually initiated with this landmark trial, the German trial, when we used actually to treat all rectal patients with adjuvant treatment for radiation and chemotherapy. But after this trial, which is a randomized clinical trial comparing preoperative versus postoperative, it was shown that the local regional control is better, the acute and late toxicity were better, and also the stoma survival was actually better. And since that time, the preoperative concurrent chemoradiation therapy became standard. And because of this trial, the researchers actually also wanted to bring the adjuvant chemotherapy also before the surgery. So there are 2 strategies, the induction and the consolidation chemotherapy. Let us start with the consolidation chemotherapy. These are the trials that have been published up to now for the consolidation chemotherapy protocol. We'll start by the most important and the most famous one is the North American trials that involve 17 cancer centers in USA and Canada. And it is a non-randomized phase 2 trial. They had actually four groups. They waited more before surgery, and they introduced chemotherapy as a consolidation in different groups. Group 2, they give 2 more cycles of FOLFOX. Group 3, 4, and group 4, they give 6 cycles. it was shown that giving more chemotherapy and waiting more actually had improved the pathological complete response. Not only that, but the update of this trial showed that there is a trend, or there is actually improvement in progression in disease-free survival, and also there is some trends of improvement in survival. So giving more therapy, more chemotherapy had shown that it also affects the survival. Another very important trial is the Polish trial. Polish trial is one of the first trials that had compared short course radiation therapy with consolidation, 3 cycles of FOLFOX compared to the concurrent long course chemoradiation therapy. There was no difference between the two, no co-regional control, but there was a survival advantage at the beginning when this trial was reported at 3 years. But when there was a follow-up of the same trial, this survival advantage was actually lost. Seems to be that the 3 cycle was not enough to maintain this overall survival. Another interesting trial is this Chinese trial. Again, they give chemotherapy followed by 3 cycles of Capox. And it was shown that there is an improvement in pathological complete response if the chemotherapy is added to the radiation therapy, but with more waiting time. So they didn't know which one is more important, the chemotherapy or the waiting time. This actually was answered by this trial. It's called the WAIT trial. Simply, they give concurrent chemoradiation therapy for both, and they waited for 10 weeks. In one group, during the waiting time, they add 3 cycles of FOLFOX, and the other group, they didn't add anything. And it was shown that the pathological response was actually similar between the two. So indicating that maybe the waiting time is more important than the introduction of chemotherapy in the consolidation part. But the most important trial in the consolidation is the Rapido trial. I remember when it is published, everybody was really happy about it. It came at the COVID time, and our radiation oncologists were very happy to practice this. So basically, it was a long course followed as usual after 8 to 10 weeks by surgery, or waiting more with giving more chemotherapy. And adjuvant is not mandatory, so only 40% had received adjuvant in the classical, in the standard arm, but all of the patients had received consolidation chemotherapy. So this is, as we all know, it is a positive trial. The disease-related treatment failure was better, and the distant metastasis was better, and we all know why. It is more chemotherapy actually was given in the experimental arm. And longer follow-up showed the same. Still, there is improvement in distant metastasis, but the local regional recurrence was worse since the radiation was less. This is a Korean trial. Again, they give only 2 cycles of Capox after concurrent chemoradiation therapy. The waiting time was the same, so there was no actual statistical significance between the two. The other important trial is the Chinese Stellar trial. It is similar to Rapido, short course followed by 4 cycles of Capox, followed by TME, followed by adjuvant of 2 cycles. So collectively, they need to receive 6 cycles, and it is mandatory. And the standard arm also received 6 cycles of Capox, which is also mandatory. So everybody received chemotherapy, and the primary endpoint was disease-free survival. It is a non-inferiority trial, so it was a positive trial. The short course was as good as the long course. And to the surprise of everybody, the overall survival was also positive. Nobody could explain why, actually. And the updated results, which was presented in ESTRO last year, the 5 years overall survival was significant. The 5 years disease-free survival was non-inferior, and the pathological complete response was better in the experimental arm. Japanese trial resembling the phase 2 trial resembling Rapido had also similar outcome with improvement of pathological complete response. So what we can get from all these consolidation trials, the consolidation trial is really good for complete pathological response, and it is very good approach for watchful waiting policy. How about induction chemotherapy? These are all the trials that have been published up till now. in the induction. We'll go through the most important one. At the beginning, this is a European trial. Everybody was really afraid to delay the surgery. So this European trial, they added only 2 cycles as an induction, followed by concurrent chemoradiation therapy, and they couldn't find any difference. So they felt that they are reassured if they can wait and give more chemotherapy. This trial is a Spanish trial. Again, they give 4 cycles of induction chemotherapy, followed by concurrent chemoradiation therapy, and they compared it with concurrent chemoradiation therapy, followed by adjuvant chemotherapy. Again, there was no difference between the two, but it was shown that those who received induction, more than 96% had completed the chemotherapy, but those who received adjuvant, only 75% had completed the chemotherapy, indicating that if you want to complete the chemotherapy, it's better to be given as early as possible. This is a retrospective trial from Memorial Sloan Kettering. They analyzed their data, large trial, large number of patients, 300 patients who received this time 8 cycles of induction of FOLFOX compared to the concurrent chemoradiation therapy, and it showed that there is started to show some difference in complete pathological response when the induction chemotherapy was compared to concurrent chemoradiation therapy, indicating that the induction also might affect the complete pathological response. But possibly the most important one is the British trial. 460 patients randomized to receive FOLFIRINOX 6 cycles, followed by concurrent chemoradiation therapy, followed by another 6 cycles of FOLFOX or the standard. As you can see here, it was a positive trial. The disease-free survival was positive, and the updated overall survival was positive. This is possibly the only trial that showed overall survival compared to the rest of the trial, with the median improvement of around 4.3 months. This is the latest trial that had been published. It published a couple of months ago in the Lancet of Oncology. It's the Italian no-cut trial. It is organ preservation. They used 4 cycles of Capox as an induction, followed by concurrent chemoradiation therapy. And again, it is similar to most of the trial. They managed to have clinical response of around 26%, and the distant relapse-free survival was 97%. And those who had organ preservation was 85%, a very excellent outcome. So what we can conclude from the induction chemotherapy, again, it can produce some higher pathological complete response, overall favorable toxicity since we are introducing the chemotherapy at the beginning, and it is more likely to complete the chemotherapy compared to the adjuvant chemotherapy. Is there a trial using both consolidation and induction? This is an interesting Chinese trial that had been presented in ASCO 2024. They used 1 cycle of Capox as an induction, followed by 2 cycles concurrently with radiation therapy, and then 3 cycles as a consolidation compared to the standard. The primary endpoint was disease-free survival, and it was actually a positive trial. The disease-free survival was positive. The complete pathological response was similar to Rapido and Prodige, and the metastatic-free survival was also positive. The overall survival was not matured enough. So let us now, compare which one is better and at what situation we could use consolidation versus the induction. 3 trials had compared this. The first trial is the very famous German rectal cancer study group. They compared induction with consolidation. They gave only 3 cycles of FOLFOX. Primary endpoint was pathological complete response. So the consolidation was better in terms of pathological complete response. The other parameters, disease-free survival, overall survival, local regional recurrence, were all similar between the 2. The other one is the OBRA trial, again, consolidation versus induction. The primary endpoint was disease-free survival and overall survival. Both were similar, but the TME-free survival was in favor of consolidation, indicating more response due to more waiting after the concurrent chemoradiation therapy. The update of OBRA had showed a similar outcome with improvement of TME-free survival. How about short course consolidation compared to long course induction? No randomized trial, but this is an interesting trial that had been reported retrospectively. They analyzed two groups, one from Colorado University Hospital, where they are actually practicing induction with concurrent chemoradiation therapy. The other group was from the Washington University group, where they actually practicing the rapido type of consolidation. And there was no difference between the two groups. So maybe this is an indication that since a short course is inferior, that's why it didn't show a difference in terms of complete pathological response between the two trials. Is there a way to find if there is small difference between the two? This is a meta-analysis published a year ago. This meta-analysis included 17 studies, 8,000 patients, and it was clearly shown that the induction and consolidation are better than the conventional type or standard type chemotherapy in terms of disease-free survival and local regional control. But when the induction was compared to the consolidation, it was shown that the induction is better, not better, actually favoring, inclined to better disease-free survival, but it's not statistically significant, and also favoring the overall survival, while the consolidation were favoring the local regional recurrence and local regional control. So after this, we can conclude that according to the patient-centered care the recommendation, we can recommend that any patient who want to have organ preservation, any patient who have low rectal tumor with threatening of sphincter, any patient who have symptoms like bleeding or pain, any patient who who want to avoid stoma, then better to consider consolidation TNT. Those patients who are having bulky lymph node, extramural invasion, may be away from an area with radiation therapy, then induction chemotherapy, induction TNT is the way to go. I just want to include this figure that I really like. It was published just a few months back from the Blue Journal, from Royal College of Radiologists. They divided patients into locally advanced, into ugly and bad and intermediate. Those ugly are the ones that metastasize and might, compromise the survival. So those who are having criteria, MRI criteria, to have an ugly disease, they are usually treated with induction, better with triplet if the patient can tolerate, or doublet. Those who are having locally advanced disease, then they can be treated with consolidation, preferably long course, especially if it is if preservation of organ is wanted. Otherwise, short course. Those who are having intermediate risk, then these can be actually de-escalated. The de-escalation can be with only concurrent chemoradiation therapy, or with chemotherapy only, like Prospect or Convert trial, or even local surgery if it is really very small. And thank you very much.
Thank you, Dr. Ali. It was an excellent presentation. So we'll leave the question at the end. So now it's my pleasure to introduce the next speaker, Dr. Fahd Al-Mikbil. He is a consultant medical oncologist in King Faisal Specialist Hospital. Dr. Fahd will speak about BRAF mutant colorectal cancer. What is the optimal sequence? Dr. Fahd, the floor is yours.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على أشرف الخلق محمد عليه الصلاة وأتم التسليم. Thank you, Dr. Abdul Hamid. Thank you, Dr. Ashwaq, Dr. Al-Garni, Dr. Kanaan, and all the supportive team on the arranging this event. So I will not be like Dr. Zahrani, who's covered excellent, detailed, deep talk about colorectal cancer. My talk is a small, tiny, about specific portion of our patient metastatic colon cancer with BRAF mutation. So I will move by this. Okay. So those are my disclosures, and I will walk you through 4 main objectives: colon cancer in the kingdom, molecular and the colon cancer. Then we will go deep in my next 20 minutes about BRAF and then colon cancer, and BRAF and colon cancer in both sitting, MSI stable and MSI high, considering we have a new trial in both sitting in the last few years ago. So colon cancer in the kingdom and in the world, let's start with the world. You can see in the north, the ASR in 100,000 is more than 26 in North America and Russia and some country in the Europe as well. We are considered as the second or the third in the category of the common colon cancer, and this is based on the WHO statistic. If you look to the kingdom registry, we are in the second, and the colon cancer representing 13%, and it's the first in the male and the third in the female, with around 10% in female. Now, let's look to unpublished data about our registry Kingfisher Riyadh that will be published soon. If you look to the colon cancer, you can see we have around 435 cases of colon cancer, and you can see 20% of them, they are metastatic with around 131 cases stage 4 colon rectum cancer. Now, molecular, we know that there are different in origin, hand gut, mid gut, right side, common in female, common in young, worse prognosis. They have different mutation, including BRAF and MSI. And in the left side, better prognosis, different mutation. All of this nothing new. We know it's a standard of care to request those mutations around 5 or 6, and each one of those have a different targetable mutation, HER2, NTRK, and G12C KRAS, MSI high, as well as my main talk is the BRAF, which represent around 8 to 10% of metastatic colon cancer. Now, BRAF mutation, it's responsible for cell growth proliferation, and again, it represents 10%, and usually the most common is the V600E. V stand for valine amino acid, 600 number, and E is the most frequent, and there are different BRAF mutation, which is around 2% that non-targetable till now, and there is no clear rule for those BRAF mutation. We know in category we have 3, class A, class 2, and class 3. Usually we are looking for class A. There are 4 methods to detect those BRAF, either as a single sequence or PCR or IHC and NTH. Each one of those has pros and cons. Usually we are doing in most of our practice as pathologist is the PCR, and to some extent IHC, and to some extent also NGS. Now, let's talk about the main thing here is the BRAF in non-colon cancer. Again, it's common in different cancer. You can see like in the CNS, for example, astrocytoma around 80%. If you look to the thyroid cancer, also the same, they have around 60 to 80%, and mainly to be more specific, anaplastic thyroid cancer. Also melanoma, 60%, and other solid cancer. So it's not GI, as we all know. And we know they are FDA approved for those in different settings, first line, adjuvant, and subsequent line, and mainly melanoma, colon cancer, and lung cancer. And we have agnostic approved here. You can see for second line and beyond for any patient with a BRAF mutation, for any patient 6 years and old, they can use the trimitinib with the dabrafenib and this agnostic approval. The response is different. If you look to the melanoma, usually they have the best, the highest objective response rate around 70%, and overall survival around more than 2 months actually. The colon cancer, a brain, astrocytoma, and then small thyroid, and so on. And that was based, you can see different color because it was different phase 2, phase 3. And we, our main focus here is the colon cancer, as I said. So they are ongoing and complete phase 2, phase 1, phase 3 trial as of today in melanoma, colon, thyroid, and then small. But again, I will focus on colon cancer. I will present some data that presented already and some data that still we are waiting for those results. But what was our standard before on those patients with the BRAF? We know it's a poor prognostic. Usually based on the TRIBE trial, we offer those triplet chemotherapy and the response usually around 12 months or so. We know there are coexisting together, the BRAF V600 and MSI around 60%, they present together. And based on this meta-analysis 2021, they still have a best or a good response if you offer immune therapy for those patients. So if you have BRAF and immunotherapy, still the BRAF didn't affect the overall survival for those patients who had both BRAF and MSI, and again, based on this data. Now, as I said, usually we offer them triplet, FOLFIRI, bevacizumab, and usually the overall survival around 2 years. And that was based on the tribe subgroup analysis. You can see the overall survival 10 compared to 19 months. And our approach before, I have a patient with BRAF, I need to know before the MSI. MSI high, immunotherapy, then second line, I will go for Bacon trial. If MSI stable, I will go for triplet. I will keep Bacon trial as second after that. However, that was changed. As we know, let's go back a few years ago in ESMO 2017, we have Bacon trial, which is 3 cohort, triplets in form of benitumab, encrofenib, cetuximab, or encrofenib, cetuximab, or the standard of care, which is FOLFIRI, cetuximab. And it was you can just, I would like to draw your attention here that also they include left side, so that means BRAF can happen in the left side as well, not exclusively in the right side. And also keep in mind, Bacon trial, they have patients with MSI high compared to Breakwater. They didn't include those with MSI high. And what was the response? We know the overall survival was similar in doublet versus triplet with around 8 months, 9 months, objective response rate 0.52 or 0.62, and all the subgroup analysis favoring the triplet compared to the control arm. Even MSI high, you can see the response, they get still response, however, is low than the other. So this is why maybe in Breakwater, they didn't, they exclude those patients with MSI high. Now, the question based on Bacon, at that time, we start to ask ourselves, doublet or triplet? So let's look for the updated 2021 from Bacon trial. They reach the same, 9 months here, 9 months there, and both with a hazard ratio 0.60, 0.61. So usually we'll go with the less toxic medication, which is encrofenib, cetuximab. If you look here to the response, they are almost the same, apart of a slightly more of triplets with objective response rate. But again, as I said, look to the side effect. You can see 10%, they have a grade 3 if you offer triplet compared to doublet. They have just only 2%. They have this GI toxicity. As well as the hemoglobin, you can see 11% compared to 4%. So there are a lot of toxicity if you use a triplet at the second line in patients with metastatic colon cancer BRAF mutant. So in 2020, they get FDA approval to use encrofenib and cetuximab. And most of us, we are using this for the last 5-6 years. However, this was changed 12 months ago when we got the FDA approval to use chemotherapy with cetuximab and encrofenib based on this trial. This trial, Breakwater, was presented last year in ASCO 2025. And again, it was a standard of care, which is chemotherapy pure. I'm not sure why they have this arm, although the standard of care, it's making sense, sorry. The standard of care is encrofenib, cetuximab as a second line and beyond. However, they make it now first line, and chemotherapy with encrofenib, cetuximab, or just chemotherapy as we are doing before this trial. And again, just I would like to draw your attention for exclusion criteria. This time they removed the MSI high, they exclude those patients unless the patient had a contraindication or ineligible to receive, for whatever reason, the immunotherapy. They have dual primary endpoint, BFS and objective response rate, and they kept the overall survival secondary endpoint. You see the BFS is double compared to the standard of care or EC, 12 months, and the same thing for the independent review with a hazard ratio 0.53. All the subgroup analysis favoring the enacrophenic, enacrophenic, Folfox, and cetuximab, and even in the left side also there are few patients that also they gain a benefit in this matter. Overall survival, we start to reach 30 months, which is we never reached this number compared to natural history of the disease that usually they have 10-month overall survival plus minus, but we with this trial almost triple the overall survival. And here is the compare the standard 15-month, 30-month, double based on this trial. However, as I said, triple based on the historical data. The subgroup analysis all favoring enacrophenic, cetuximab, and the chemotherapy. And that's also there was a cause for this, which is toxicity. I believe all of us we use it, and the most common side effect they have fatigue as well as the nausea and vomiting. You can see the grade 3 toxicity slightly 20% more and chemo with the EC or with the enacrophenic, cetuximab. Those are related, yes. Still, they have 20% treatment-related adverse events, 58 compared to 76. Now, let's look deep, which kind of side effect. You can see the anemia, one of them, 15% compared to 3 or 6, and the EC only, as well as you can see the neutropenia. They have 15% compared to 10. Also, I was wondering why there are lipase increase. There is any 17% you can see in the bottom of the table. However, there was no pancreatitis, and usually it's reversible and something related to the immunoglobulin more than anything. So the last two slides that I would like to present is if I have a patient with MSI high and the BRAF, as of today, we still offer immunotherapy as based the meta-analysis that I mentioned a few slides ago, and that was published in 2021. But keep in mind, there are ongoing trial called CMARC phase 2 trial. They want to give patient enacrophenic, cetuximab with pembrolizumab, and the primary endpoint was BFS. We are waiting for this. Now, what about MSI stable, which is the majority of the patient to some extent, that they have MSI stable with a BRAF? Do we have a data? Yes, all data. If you looked back to ASCO 2022, this time immunotherapy was nivolumab. So nivolumab, cetuximab, and enacrophenic. Again, this is phase 1-2 trial, and they looked just only for objective response rate, 26 patients, and the objective response rate was around 45% only. And they are start to recruit for a randomized phase 2 trial to evaluate the role of nivolumab, cetuximab, enacrophenic, and MSS BRAF mutant metastatic colon cancer. So the take-home message is simple, that molecular testing is a must in metastatic colon cancer, and I will add, as Dr. Benjamsa mentioned, even for ALE, we have to request MSI status as well as other in metastatic colon cancer. The standard of care as of today, January 24, 25, 2026, is to give chemotherapy with EC for those patients with a BRAF metastatic colon cancer in the first line. Thank you so much.
Thank you, Dr. Fahad, for your excellent presentation. So now I would like to invite the speaker of this session to come to the stage, Dr. Ali Zahran and Dr. Karam Shamari. So if there is any questions, or I might start with probably asking Dr. Kanaan about his talk about the role of CTD in It's fascinating now to see this evolving role of ctDNA, Dr. Kanaan, and just my question, do you see it coming like soon to have ctDNA part of our routine practice, or should we still wait more? And also at the same time, what is the endpoint that we should look for? We know this is like biomarker. So what is the biomarker that, or what is the endpoint that we should focus on to have these biomarkers as acceptable to be in our practice? And in terms of endpoints, anything you think of, it's difficult to see overall survival for these biomarkers, but what do you think in terms of recurrence? Any question, Dr. Abdullah?
And definitely it's not going to be predictive. I don't believe anything soon. I think the idea of the MDR is more important than ctDNA, so I totally agree with you. Now for Dr. Fahad Mikdad, patient who is a BRAF muted with liver limited and peritoneal. I know most of the surgeons, they are, they don't like a patient with BRAF muted. And most of the time, they actually reject to do any liver resections or peritoneal hybic and peritonectomy with a positive the BRAF. So do you think now with the breakwater going to change the thoughts about this, type of patient or populations? And the last question for Dr. Ali Zahrani, upper rectal cancer, T4 and 2. Do you think that we need to go with Rapido or shall we go with the Prodric for the upper rectal?
Thank you, Dr. Shurb, for this great question. You're absolutely right. It was one of the negative prognostic factor. If any patient have BRAF, even now we know it's the criteria for transplant. It's completely one of the main thing that immediately they will be excluding those patients, even with a good response, considering the natural history of the BRAF mutant of those patients. Is it the time now? I think yes, maybe. Still, I don't know. The data is promising, as we can see in the Bacon as well as Breakwater. They reached the survival of 30 months. So why not to go and walk extra step for those patients with either transplant or with either cytoreductive surgery and HIBIC? I think it's worth exploring this, but it will not be my option A or standard of care, or I will be immediately encouraging to go ahead for those. If I have a patient with a good long response, at that time, yes, I will explore it in my MDT with the surgeon and also discuss with them the recent result of this Breakwater. I'm eager to wait for the adding immunotherapy for those patients, especially, MSI high, not MSS as per the nivolumab trial. And I want to see what will be the result for this phase 2 trial. This is regarding your question for me, Dr. Zahrani.
I think this is very important, Dr. Abdullah. You are absolutely right, But, currently they are considering upper rectum as colon. If you have colon, which stuck to the other structure, what you're going to do? Give radiation? You start with chemotherapy usually. Yeah? So now the treatment is actually, we are trying to, the problem with the upper rectum also the drainage. It drains to the upper aortic area. Waiting for long course, this will never be covered by the radiation. The radiation usually covers the pelvis. So again, I think it's, just as a compromise, if it is involving the nearby structure, we give short course, and then you give the chemotherapy, and then you go for the surgery.
I have a question also to Dr. Zahrani about rectal cancer for those who have high-risk disease, especially T4B. This kind of population are not well represented in all the trials, those who have invasion to nearby structures. So what do you think, what is the best way to go with these patients in terms of sequencing the treatment, or which chemotherapy is better than another? What is your thought?
When we look to the risk factor, we are not looking to one criteria. We need to look to the others, and we should really balance. T4B is usually a local problem. So if it is, still in the middle or lower rectum, I think consolidation is the way to go. But if you tell me that it is associated, for example, with lymph node, N2, extramural invasion, then this is something else. But at the end of the day, by the way, there is a shadow. You cannot just decide you're going for this or going for that for special criteria. You really need to discuss it with the radiologist. And by the way, the radiologists need to be very, specialized radiologists to tell you exactly. Sometimes some of the radiologists actually they overestimate, just to be in the safe side. And we really need to be careful, and we really need to discuss this and know exactly what is happening. If it is pure T4, then I think it is consolidation way of treatment, and then we'll give the chemotherapy later.
Right. So now we'll move to some questions from the audience. I think there was a question from Dr. Muad about the role of atezolizumab as adjuvant for stage 3 high-risk colon cancer. I know this is for Dr. Fahad, but maybe we can ask all the audience. What do you think?
Fahad, he will replace Fahad. I will replace Fahad. So now there will be a conflict here. MSI high, adjuvant stage 3. You're supposed to follow the atomic trial and to give the combination for 3 months, then continue atezo alone. But the patient is not fit for the chemotherapy. So if the patient is not fit for the chemotherapy, first of all, most likely he will be not fit for the immunotherapy. This is one. Two, if the answer here will be, just give him the immunotherapy. The question is if the patient have a recurrence later on, what I will give him. The third point is the synergistic effect I will lose it between the chemotherapy and the immunotherapy. So I don't think I will face this kind of scenario. This is one, because if the patient is not fit for the chemotherapy, he will not be or she will not be fit for the immunotherapy. And if I have a patient in this scenario, I will discuss with him. I will not say, you just, the next step is observation. There is a possibility to offer immunotherapy for you that may decrease the risk of recurrence in the future. And the date, we do not have data here. But again, I will explore it. I will not say, there is no option. No, sometimes you are deviating and you can extrapolating from here and there. I'm not sure if someone against this idea. Dr. Shul.
So, Fahad, thank you so much. Now, we know clearly that from the COMET trial, that atezolizumab is underperformed compared to pembrolizumab and Nivo AP. And definitely for those category of patients, they include also the BRAF mutant. So I don't know who is this patient that he has both, high MSI and BRAF mutant, which could be seen. I do believe I am going to observe the patient until he becomes metastatic disease. Then I may consider immunotherapy at that time. I will not jump for atezolizumab as an adjuvant setting as a monotherapy.
And there is one extra point, excellent point from Dr. Karan. Usually we are not requesting for BRAF in those stage 3. But again, yeah. Dr. Abdul Hamid.
So just I'm looking to the audience question. So we have a question from Prof. Hussam Shabana. What are the most recent biomarkers for confirming patient with cancer pancreas? And when we start the proper management after suspicion or after confirming? It's open for all the audience, and that's beyond the lower GI as well. But anyone can comment, or we can move to other questions.
Unfortunately, pancreatic cancer, there is no much targetable mutation. However, there is less than 1% of NTRK that no one requested, and usually there is a tumor mutation burden. And honestly, I have one patient with a tumor mutation burden that she responds for almost now 6 months to some extent. And MSI also around 2-3%. The KRAS, which one? The KRAS G12? G12C, the same, isn't it? G12D is the one that they have a lot of targetable or a lot of trial that ongoing in the vaccine and this and that.
Yeah.
Pancreas.
Yeah. Yeah, so I think he's asking about the diagnostic investigation. So for localized pancreatic cancer, resectable upfront, they can go for upfront surgery. There is no need for biopsy. But if the patient is with locally advanced, unresectable, or metastatic, you need to have a histology confirmation of metastatic disease. Yeah, see, the CA19-9 can be helpful, but it's not a diagnostic, of course.
Any further questions? If no يعطيكم العافية جميعا, I would like to thank all the speakers.
So thank you very much. It was an excellent session. I would like to thank all our esteemed speakers, moderator. I would like to thank also our attendees, physical and virtual attendees. I also would like to extend our thanks to our sponsors and to our supportive team, Mohammed, Jason, Hanan, and the rest of the team. Thank you very much. And hopefully we'll see you again in another educational meeting. Assalamu alaikum.
السلام عليكم ورحمة الله وبركاته. شكرا جميعا للانضمام لهذا الحدث الطبي. نشكركم على حضوركم وعلى وقتكم. الآن موجودة على الشاشة جميع التعليمات الخاصة بالمنظم لعملية الحصول على ساعة التعليم الطبي المستمر. نرجو منكم قراءتها. كل من قام بتعبئة الفورم سنقوم بإرسال بياناته للحصول على الساعات، ولكن إذا لم يحصل على الساعات فهذا يكون بسبب اختلاف التصنيف في الهيئة. نشكركم، وقمنا أيضا بمشاركة أنشطتنا القادمة في الشات بوكس، فالرجاء القيام بالتسجيل في المؤتمر القادم الأسبوع القادم إن شاء الله. وبعد ذلك سيكون هناك مؤتمر خاص بسرطان الثدي Breast Cancer Conference Meeting in February. شكرا لكم على متابعتكم، شكرا لكم على انضمامكم لهذه الفعاليات العلمية، ونرجو لكم يوما طيبا، والسلام عليكم ورحمة الله وبركاته.